Ìgbàanú tó lè wá, ìfọ̀rànlọ́wọ́ tó lè wá, níbi ìjókòó. Àkáfólù gbé ìṣòro ọmọ ìyá. Ó ṣe fún ọ̀gá mẹ́tẹ̀ẹ̀lá kìí ṣe ìjókòó. Kìí ṣe ẹjẹ́ ka Kùránì, ẹjẹ́ á ṣe àkídà, ẹjẹ́ á ṣe nóò.
Good morning, everyone. Welcome to this week's episode of our weekly, weekly seminar presentation. And this week we are starting with women's health university. And in our lead is Dr. Sarah Ali, and she is going to take us from basics of assessment and rehabilitation, basics of pelvic floor assessment and rehabilitation. So you're welcome, ma'am. Good morning once again. I think it is now 10 minutes past 10. We can start the presentation now. Thank you.
Yes, hello, good morning, everyone. My name is Sarah Umar, a pelvic and women's health physiotherapist. Please, am I audible, please?
Yes, ma'am. Yeah, audible.
Okay, I'm audible?
Yes.
Okay. Good morning,
Audible.
everyone. My name is Sarah Umar Aliyu, a pelvic and women's health physiotherapist from Rashid Shakwani Federal Teaching Hospital, Jigawa. I'm here to give some basics on pelvic floor assessments and rehabilitation. Let me share my screen. Sorry, I'm sharing my screen now. So please, my screen is visible, please. Hello?
Yes, it's visible.
Okay, thank you so much.
Yes,
Basics.
yes.
Okay. Basics of pelvic floor assessment and rehabilitation. In pelvic and women's health physiotherapy, the main thing is we are more concerned is the pelvic assessment. The pelvic and women's health physiotherapists, before we are just women's health physiotherapists, but now we join the trend of the world to pelvic and women's health physiotherapists. The pelvic incorporates the pelvic of the children, the men, and the woman, irrespective of age. So now we want to know some basics of the pelvic floor. Understanding the pelvis is very important, and the pelvic floor as well as the pelvic floor muscle is very important, because you cannot just start assessing the pelvis without having some knowledge of the pelvis as well as the pelvic floor. So now we want to do some recap. I know almost all of us know the pelvis as well as the pelvic floor, but we want to get some recap for more understanding of the assessments. The pelvis, yes, the bony pelvis is a bony cavity located between the abdomen and the legs. That is, it's in between our legs and the abdomen. That is where the pelvis is located. It is made up of hip bone, comprising of the ilium, ischium, and the pubis, and the sacrum and the coccyx posteriorly. They are joined together anteriorly to form the pubic symphysis joint, and posteriorly we have the sacroiliac joint, we have the sacrococcyx joint. The pelvis, it has three major walls. That is the anterior wall, the posterior wall, and the two lateral walls. The pelvic joints are supported and strengthened by strong ligaments. They receive the arterial supply largely from the internal iliac artery and innervated by the sacral and coccygeal nerves. The pelvis is drained mainly by the internal iliac vein. This is the pelvis. This is where the pelvis is located between the abdomen and our legs. And these are the bones that join together to form the hip joint. And these little lines here are the sacroiliac joints. And this is the sacrum and the coccyx below. And anteriorly is the pubic symphysis. There are different types of pelvis. The pelvis can be gynecoid, which is the majority of women that have it. The gynecoid or the genuine pelvis, it is round and wider with less prominent ischial spine. The ischial spine are not that prominent, especially in women, due to the presence of the large gluteal muscles. Then the android pelvis is heart-shaped brim, and it's narrower than the gynecoid, and it has the prominent ischial spines, especially found in males, because there is the gluteal muscles are not well developed than in gynecoid. Then we have the anthropoid and the platypeloid, which is shallower than all the muscles. Here is it's a beautiful picture explaining the pelvis. This is the android, the one that it has the prominent ischial spines are prominent. These are the ischial spine. They are prominent, and is narrower than the gynecoid. This is the gynecoid. About 41% of women have this gynecoid, and the ischial spines is not so prominent and is wider to allow for easier childbirth. And these are the other two, the anthropoid and the platypod, which is the less occurring, is only found in around 2% of women. Okay, let's move on. Since we are dealing with the pelvis, not only the female pelvis, so now we want to understand the difference between the male and the female pelvis. The female pelvis is oval-shaped, broader, and has a wider outlet. God designed it to be wider because women carry a baby in her womb and it will pass through the pelvis for delivery. That is why it is naturally designed to be wider to allow for easier childbirth. While that for a male, it is like a heart shape and it has a wider back and the pelvic brim is not as big as that for the female. The pelvis is divided into false pelvis, that is the greater pelvis, and lesser pelvis, that is the true pelvis. The true pelvis is the major one concerned for obstetric and gynecological significance because it's where the pelvic organs are, the pelvic floor muscles are, is of major importance. Okay, this is a picture depicting the male and female pelvis. From the outlook, we can see that the pubic arc here is narrower in male and the pubic arc here in female is wider because during delivery, it has to expand well to allow for easier childbirth. And also all the structures you can see is wider and is shallower than that of male. This is another beautiful picture also explaining the differences for more understanding. The bones in male is heavier and thicker, but that of female is lighter and thinner because if it's heavier and thicker, it will be hard for the bones to give way for delivery. Then, okay, we are moving on. The pelvic organs. The pelvic organs are encased inside the pelvic cavity. And for male, it consists of the bladder, the uterus, and the rectum. For female, it consists of bladder, prostate gland, and the rectum. These pelvic organs are kept in place with the help of the pelvic floor muscle from below and with the help of pelvic ligaments, strong ligaments attaching these organs to the wall of the pelvis as well as to the pelvic floor muscles. In any situation where the pelvic ligaments become lax, it will make the pelvic floor muscle to sink down and the result is prolapse of the pelvic organs. Or in a situation where the pelvic floor muscles are weak, the ligament cannot sustain the heaviness of these pelvic organs. So in a small time, the ligament will lose their elasticity and the pelvic organs will descend down, leading to a prolapse of any of the organ, either the prolapse of the bladder, that is the cystocele, or the prolapse of the rectum, that is the rectocele, or the prolapse of the vaginal wall, leading to vaginal vault or pelvic organ prolapse, then the uterine prolapse. This is a picture showing how these organs, this is bladder, the uterus, and the rectum, and this line is explaining the pelvic floor muscles, and here is the coccyx posteriorly and the sacrum, and anteriorly the pubic bone. These muscles are attached to these bones with the help of strong ligament, and also these organs are attached to the pelvic organs with the help of strong ligament. A small increase in pressure, intra-abdominal pressure, will lead to sinking of this abdominal muscle down. If the pelvic floor muscles are not that strong to accommodate the increase in the abdominal pressure, there will be descent of these organs, especially the bladder, because it's more anteriorly. Then that is why many female and some men, they usually complain of leakage of urine when there is an increase in intra-abdominal pressure. Okay, this is male and female pelvic organs. As I stated it before, the female pelvic organs consist of the bladder. This is the bladder. It is anteriorly placed, attached to the pubic bone, and behind it is the uterus. Here is the uterus, and the uterus is attached to a tube called the vagina, that is called the vaginal tube, open to the vaginal orifice, and behind the uterus is the rectum. This is it. And for female, the bladder is here, anteriorly also, and below the bladder, there is prostate, which is responsible for storing of the semen and excretion of some fluids during ejaculation, and it's attached to the penis, leading and outside to the urethral opening. And in male, there is no uterus, so the place is empty. Then move back posteriorly with the rectum. Here is the rectum open down to anus. Okay, let's understand the bladder. Bladder is placed anteriorly in the pelvis. It is a hollow sac. It's about 4 centimeters long. It is made up of 3 muscles. The outer is the peritoneal muscle, and the middle, the destrusor muscles, and the inner mucosal muscles. Its outside surface is covered with connective tissues that are composed of elastic fibers and collagen for it to be more elastic. Its shape varies depending on its shape. It's usually round in shape, but the shape varies depending on the size. What I mean by the size here, depending on the collection of urine in it. Without the collection of urine, because it cannot stay without collection of urine. With small collection of urine, the size is small, but it begins to expand as the urine collection continue to increase. And its position, it's usually within the pelvis, but once it's full, it's protrude to the abdomen. It protrudes to the abdomen. It is a temporary reservoir of urine. A normal bladder can store about 400 ml to 600 ml of urine. The urine enters the bladder through 2 tubes, that is the ureters. The ureters are long, about 25 cm long. They are from our kidneys down to the bladder, where they collect urine and store it in the bladder. Then once there is filling of, once the bladder is full, then the urine leave the bladder through the urethra, about 3 to 4 centimeters long in female. It's not that too long. And in male, it's about 18 to 20 cm in male, because it has to go through the long penis to come out through the urethral opening. Then it's supported by strong ligament. There is the pubovascular ligament. It's attached the bladder to the pubic symphysis, that is anteriorly. The anterior joint pubic symphysis is attached the bladder to it to prevent falling from the organs. Then there is internal iliac arteries and veins. There are the main arteries that supply the bladder, and the nerve supply consists of both sympathetic and parasympathetic fibers. Here is some diagram showing the kidneys. The ureters are these long tubes collecting urine and store it in the bladder. And this is the bladder, is inside the bladder showing the muscles. This is for the male. As I said, is the urethra is so long because it has to pass through the long axis of the penis, and also it has to Yes, it has to pass through the long axis of the penis, and from here we can also depict it. And this is the prostate hanging behind below the urethra. Sorry, below the bladder. Okay. Then we are moving to uterus. Yes, uterus is only found in female. It is a hollow organ, a very important organ for reproduction in female. It is hollow organ with thick muscular layer, approximately 7 centimeter long and width about 4 centimeter. It is embedded in shape. It's around like a pear shape, but its shape depends on the maturity of a female. In children, it's like a pea, a very small nut. And when the female begin to mature, the uterus begin to grow, and it reach its peak during reproductive period. It's divided into 3 parts. It has 3 parts. It has the bundles. That is the upper part of the uterus. Then it has the main body, and it has the main body where the baby grows, and the isthmus, that is the lower part of the uterus where it connects to the cervix. The cervix then from there, it's connected to the tip of the vagina. It has 3 layers: the endometrium, the myometrium, and the perimetrium. Perimetrium is the outer layer, and the myometrium is the middle layer, and the endometrium is the inner layer. It's thick and rich in blood supply. The fallopian tubes are attached to the uterus from either sides. The fallopian tubes are also attached to the ovaries. That is, the ovaries, they are the primary reproductive organs, depending on, and this size, as I explained, it depends on the female reproductive phase as well as the response to hormones. In female that undergone menopause, they are matured, but the uterus begin to shrink because the hormones that give the, sorry, someone is, the uterus, let me continue. The uterus, it depends on the reproductive phase of a female, as well as the response to certain hormones. If the hormones cease, that is around during menopause, the uterus shrink and there is no more menstruation, then all this will lead to the uterus size to diminish. This is it. This is the what I explained, the fallopian tubes. These are the fallopian tubes. These are the long tubes. They collect the egg and transport it through the fallopian tubes and into the uterus for fertilization. And this is the cervix, is the down area of the uterus connected to the tube of the vagina. Sorry, are you hearing me?
Yes, ma'am.
Okay, thank
Yes,
you.
ma, we can hear you, ma.
We are hearing you.
Okay, thank you, ma'am. Okay, then we are moving to rectum. The rectum, that is the posterior organ in the pelvis. It's found in both male and female. It is a long continuous tube at the end of the large intestine, about 6 inches. It begins at the height of S2 to S3 and end at the perineum. The rectum stores feces before it leaves the body through the anus. It's supplied by superior rectal artery, middle rectal artery, and inferior rectal artery. Venous drainage is by superior, middle, and inferior rectal artery. This is sorry, I think there is some problem. I cannot change the slide again. Sorry, please.
You can close it now and open it again. Share it again.
Sorry, I cannot change the slide. I'm checking on it.
I think you can stop sharing it and share it again.
Sorry, what you said? I should share
You
it
can stop.
again?
Yes.
Okay.
It has changed now. It has changed to prostate gland from the
Okay.
former one that you explained.
Okay. Yes, it's changed now. Okay, now we are moving to prostate gland. I don't know why it's taking time. Yes, now it's changed to prostate gland. Sorry, yes. Yes, it's moving now. So sorry, I don't know what is taking this problem. Yes, the prostate gland. The prostate gland is only found in male. It is a gland located below the bladder and in front of the rectum. It's about a well-known size, about 30 grams, is so small. It's composed of connective and granular tissues. It plays a vital role in semen production and ejaculation because it also adds fluid to semen and help in pushing semen through the urethra for ejaculation. Oh. Yes, the female and male external genitalia. Now we understand the pelvic organs, as well as the ligament also supporting the pelvic organs. So now we are moving to the external genitalia. That is what you see once a male or a female lie down in front of you, undress herself and open her pubic area. What we are expected to see there, that is what we are going to discuss now. Let's start with female. In female external genitalia, you start from you will see the pubic hair. The pubic hair is located above the mons pubis. Then from the mons pubis, then there are two lips by the side, that is the labia majora. Apart from the labia majora, once you part the labia majora, there are two small lips again, that is the labia minora. The clitoris is just below the mons pubis, where the labia majora starts, that is the clitoris, but the clitoris is not visible completely outside. It's only the glans of the clitoris is visible outside. Then the vestibule area. The vestibule area, it's where the vaginal and the urethral opening are. Once you part the two major lips, that is the labia majora. Then coming down, you come to the perineal body, that is the place where between the vaginal opening and the anal opening, that is the perineal body. Then down to anal opening and the anococcygeal body. That is for the female. And in male, you only see the pubic area, the pubic hair, the penis, and the scrotum. The scrotum contains the testes. For the female, this is what I'm explaining. This is where the hair is at the top, and this opening and that little small opening is the urethral opening, the vaginal opening. There are three openings: the urethral opening, the vaginal opening, and the anal opening. Then there are two little openings that are the glands, the Bartholin ducts and the Scalene gland. They have two openings where moisture or secretions are passed during maybe sexual activities. And this is the clitoris. This is the shape of the clitoris. We can only see the clitoral gland outside, but it's as big as this inside. It has a gland. It has a crus, that is the legs, and it has a bulb. They are They are all inside and they are as big as penis when compared in size. And this is the vaginal canal. That is where this at the top is the cervix, where it connects to the uterus, and this out, then there will be no sexual sensation. Then for the male, we can only see the penis, the scrotum containing the testes, and the pubic hair. The male and female external genitalia are supplied by its supply is through the sacral nerve S2 to S4, while the female is also through internal and external pudendal, for the male through the internal and external pudendal artery. Drainage is through the external and internal pudendal vein, and a drainage of the female external genitalia, it drains toward the superficial inguinal lymph node, except for the clitoris that drain towards the deep inguinal lymph node. Nerve supply is from the pudendal nerve, as I stated before, and also the penis is also supplied by the pudendal nerve, splenic nerve. So now we understand the pelvics and the pelvic organs. Before we proceed, is there any contribution or question from anybody before we proceed? Or we can proceed? Hello?
Yeah, let's proceed.
Okay, let's proceed. Thank you. Then the pelvic floor and the pelvic floor muscles. The pelvic floor. The pelvic floor is a funnel-shaped structure. It spans the pelvic outlet to support the abdominal and the pelvic organs. It has two significant holes, that is the urogenital hiatus and the rectal hiatus. The urogenital hiatus anteriorly allows passage of the urethra and the vagina, while the rectal hiatus allows the passage of the anal canal. It further divides into two triangles. We can say the urogenital triangle and the rectal triangle. This angle consists of the pelvic floor consists of muscles, fascia, and ligaments. The muscles and the fascia and the ligaments are those that match together and support the pelvic organs. Instability in either the pelvic organ or the ligament can lead to prolapse of the abdominal content. Then the pelvic floor muscles. The pelvic floor muscles, they are a group of muscles that are encased in a fascia and form the floor of the pelvic basin. They are like a diamond shaped, just because they start from the pubic symphysis anteriorly, they span laterally to ischial tuberosities, and they go down to coccyx. They form something like a diamond. They are firm and thick in nature and is stretched like a hammock from pubic anteriorly to coccyx posteriorly and laterally to ischial tuberosities. It has different types of fibers. There are slow twitch fibers and there are fast twitch fibers. The slow twitch fibers are about 70% because they function in maintaining the tone of the muscles, because they are the major muscles that aid in support of the pelvic organs. And there are fast twitch fibers because they quickly act when there is a slight increase in abdominal pressure to hold the organs in place to prevent any prolapse or any leakage of urine. This is the diamond shape that I'm talking, starting from the pubic symphysis to ischial tuberosities and down to the coccyx. The pelvic the floor muscles are lined in 3 layers. They are lined in superficial muscles, the one that you can see. Let's say once you remove the skin of the external genitalia, they are the first muscles that you see that are the superficial muscle. Then going down is the middle one, and deep inside are the deeper muscles, that is the levator ana and the coccyx. The main function of the pelvic floor muscles is pelvic organ support, as I explained before, bladder and bowel control. They give control to bladder and bowel because they prevent leakage of urine and leakage of feces, because the pelvic floor muscle they remain in small tone. They can never relax completely, because if they completely relax, if they are relaxed completely, it can lead to leakage of urine or fecal, maybe while we are sleeping. If they are completely relaxed, you will just wake up in a urine or in pieces. They remain in small tone because that small tone aid in prevention this leakage of urine or the pieces. However, this tone is voluntarily controlled. Once you want to pass the urine, you voluntarily rest the muscles and you pass the urine, or you pass the gas, or you pass the pieces. They also help in sexual function because these muscles are so important in sexual activity. Without the good functioning of this muscle, there will be no pressure, there will be no sexual pressure. Then breathing, yes. Breathing, good. If these muscles are functioning well, there will be good breathing, because if the muscles are in place, let me see the pelvic muscle, that is the core muscle. No, the core muscles, they are like a cylindrical muscles covered from the top by the diaphragmatic muscle, down the pelvic muscle, in front the abdominal muscle and the back muscle. They are like cylindrical muscle. Any dysfunction in any of this muscle can lead to affectation of the other side. If this pelvic floor muscle are dysfunction, they are weak, even the breathing will have, there will be difficulty in breathing. The breathing will not function very well. They might end up to breathing with their bellies, not with their chest, especially in people with asthma. They have this problem. Then they play a role in pregnancy and childbirth, just the way I explained before. The superficial layers. The superficial layers consist of bulbocavernosus, ischiocavernosus, superficial transverse perineal, and external anal sphincter. Let me use this diagram and explain it more. This is the male pelvic floor organs, and this is for the female. This pink color is the bulbocavernosus. It starts from the perineum going up into the clitoris. It covers the bulb of the clitoris, attach itself to the cavernosa of the clitoris around this place. Then this green one is the ischiocavernosa. It starts from the pubic, the ischial rami, the ischial tuberosity, up to the clitoris, covering the crus of the clitoris. Also, likewise in male, this pink one is the bulbocavernosa, starting from the pineal body up to the superior part of the penis inside, and this green one is the ischiocavernosa, from the ischial tuberosity up to the body of the clitoris. These two muscles are so important in sexual activity because if they are function so well, sexual activity will be so pleasurable and memorable. Because in female, without good function of these two muscles, there will be no sensation. That is, the penetration there will be no sensation that will lead to orgasm. And in male, these organs are responsible for sustaining a good erection for sexual activities. Then coming down to this light green color is the superficial transverse perineal. It it's a stabilizer muscle attached either side of the ischial tuberosity from the perineal body down to the ischial tuberosity. These are the transverse perineal muscles. Also, this is for the female. They are stabilizers. They hold the ischial tuberosity by the side well. They hold the ischial tuberosity by the side very well and stabilize the pelvic in place. Dysfunction of this muscle, especially in female during delivery, there is episiotomy. There is cut into this muscle, and this lead to the stability of this muscle. And at the end, it might lead to back pain, sacroiliac joint dysfunction, because the stability of the pelvis is distorted. Okay, then the external anal sphincter for male and female, this bluish one is the other superficial muscle. Then the middle muscle, that is the deep perineal pouch, consists of compressor urethri, the external urethral sphincter, ureterovaginal sphincter, and deep transverse perineum. These muscles are responsible for continence because they aid in maintaining urinary continence for male and female. And then the deep layers that are the pelvic diaphragm consists of levator ani and the coccygeals. The levator ani are the most important muscles. They are the most important muscles in the pelvic floor muscles because they span the pelvic floor like a hammock. They cover the pelvic floor, and it's divided into fubococcygeals and iliococcygeals. Then the fubococcygeals in some literatures also subdivided further because it's from the name fubococcygeal, it starts from the pubis and coming down to the coccyx. It's a long muscle starting from the anterior and up to the posterior side of attaching itself to the coccyx. So in some literatures, they divide these muscles into, they name it into pubovisceralis. That is, it attaches itself to different viscera in the pelvic floor. At the beginning, it attaches itself to the urethra. That is the pubourethralis. It only comes from the pubis down to the urethra and it stops there. Then continue this, because according to people, they said if it spans the urethral opening or the vaginal opening or the anal opening, there will be no release of urine, there will be no sex penetration, there will be no passage of pieces. So the muscles are, they stop at the urethra and to allow the urethral opening, that is the pubourethralis, and continue to the vagina, that is pubourvaginalis, and down to the perineal body, that is pubourperinealis, and going down to the anal side, that is the puboanalis, according to some literatures. All these muscles together, the pelvic floor muscle, they work in harmony to support, stabilize, and as well as to function in sexual function. These are the muscles. These are the superficial muscles. These are the middle muscle, and these are the deep layers. There is some acronyms for easier understanding. That is SBE, superficial, transverse perineal, bubococcygeals, iliococcygeal, and anal sphincter. For the middle one, destructural effect continence. The D is for the deep transverse perineal. The E is for the external urethral compressor, and the C is for compressor urethri. Then for the deep layer, they usually use can I please P, C, coccygeals. Then the levator ani consists of the iliococcygeals, pubococcygeals, and puborectalis. It's the puborectalis that I just give the explanation. According to some, it's now the pubovisceralis. Thank you. Okay, we are moving to pelvic floor assessment. Can we move on, or there is something that need more clarification or some contribution? Hello? Hello?
We can
We
can
move
hear
on.
you.
Okay, thank you so much. Then the pelvic floor assessment. Pelvic floor assessment is very important. Once you understand the pelvic, because it's good to understand the overview of the anatomy that we just discussed, it's good to understand it because you have to educate your patient regarding all these muscles, the pelvic organs, the pelvic bones, for more understanding of him or her condition, because patient education is so vital in patient assessment as well as good treatment. Once the patient understands what is wrong with him and you explain the things that he need not to do or that will make what his condition is, that will make his condition worse, he will be very careful in adhering to all you tell the patient. There are some things to consider before starting the pelvic floor assessment. Firstly, as I said, patient education about the assessment procedure. You have to, at the beginning, people that have pelvic floor problem, they are shy. Mostly, they don't even come to us. They usually stay at home and maybe to taking some advice from others. Those that even come to us, they take a very huge step in their rehabilitation. That is the one step. For the patient to be so comfortable and to adhere to your assessment, you have to make the patient more comfortable with you before you start the assessment. Talk to the patient, even create some gist, make him laugh, make him him or her to be more comfortable with you before you start even talking regarding undressing the patient, because some people might not agree with the assessment. You have to create a good understanding between you and the patient. Talk to the patient, show him concern, show him you care about him. Then you gradually introduce the assessment to him. Tell him the procedure. Tell him that I want to check you. I want to know what is exactly wrong with you. And for me to understand and know these things, I have to check you down. Could you please allow me to do that? Because without checking and knowing exactly what is wrong with you, I might be wrong in prescribing a good management for you. So the patient will be at ease. Then you explain the procedure. You have to lie down. You have to remove your underwear. You have to expose your pelvic, the pelvic region. I will use my clean hand to check the area, the outside area, and if possible, to insert my finger into your vagina or into your rectum, into your anus, and assess what is exactly wrong with you. That is, you explain the full procedure, the assessment you want to do. Then you educate him regarding the pelvic floor, just the way I said. That is the reason for the first knowledge, the overview of the pelvic floor we had. Then you seek for the patient consent. Make sure you seek patient consent, because anything might happen and the patient might do something that is illegal, especially in female. Many male, before you start seeing them, they will be feeling somehow. Even your female partner, they will start feeling somehow. Once you collect the patient consent, it has to be written consent. It's a very good thing. It has to be written consent. Then the room that you want to do the assessment, it has to be well-ventilated room with adequate lighting for you to see the areas you want to assess. Then it has to have all the necessary things like a tissue paper, like gloves, because you need to wear gloves. You need to have something like a curtain or a cotton board. You need to have a dustbin by the side, and there must be an assistant, because you cannot be checking someone and you go and take something and come and continue. You have to have an assistant, and if possible, the partner, either male partner or the female partner, depending on whom you are assessing. Then the person has to have a full bladder in case if the condition you are suspecting is hypertonic pelvic floor condition. What I mean by hypertonic, that is, if from the patient history, you think there is leakage of urine, there is descent of the pelvic organs, there is lack of sexual sensation, or there is lack of the penile erection, these are all due to hypertonic pelvic floor dysfunction. And for this, the bladder needs to be full. If the patient bladder is not full, you need to ask him to take some water before you start the assessment. And for hypertonic pelvic floor, like in case of spear pain, in case of spasm, the patient need to empty their bladder, because a slight increase in urine in the bladder will also trigger that painful sensation. So the person need to empty his or her bladder. Then from there, you wear your gloves, and if possible, use a lubricating gel. For the external assessment, you have to lubricate your finger and make sure the gloves are sanitized. They are good gloves, because you cannot transfer infection to your patient. At the beginning, you observe the perineal and the vulvar area. You observe any sign of infection. If there is any sign of infection around the vulvar area, there is no need to continue with the assessment, because you might transfer infection from outside to inside. You can assess the infection by seeing the hygiene of the area. Maybe the place look bushy, smelly, there is some discharge. Like this, you can ask the patient, we need to arrange time for another session. Don't talk to patient that you have an infection, you are not clean. No, you have to make a good rapport with your patient, talk to her or talk to him in a good manner, that we need to design another time for this assessment. And before then, you need to clean up, you need to do some shaving, you need to do some kind of things that will make the place good. Just explain it to her, it's part of your management. Don't tell her that she is not hygienic, because she might or he might not come back for the assessment. You ask the patient for history of sexual abuse, and if the patient is menstruating, even before, the menstruation, you have to ask for menstruation even before you start the assessment, because if she's on her menstruation, you can schedule another time until when she is off. And as I told you, internal examination is contraindicated in female if she is less than 6 weeks postpartum, because the place is already tender. After delivery, it needs to have some rest, at least 6 weeks postpartum. And if the female, according to literature, is less than 18 years, but in this our area, by 18 years, some people have like 2 or 3 children. So this is for the literature. And had pelvic surgery recently, about 3 months ago. She had pelvic surgery. So this woman is not qualified for internal examination. So the pelvic floor assessment. For any good assessment, the first thing is subjective history from the patient, a comprehensive patient history. You have to ask the patient comprehensively. You need to allow the patient to narrate her story. This is before even starting the assessment, because allowing the patient to narrate her story and sympathize with her, follow her with whatever she's saying, will make her more comfortable with you before you even come start for the assessment. You ask, what is your exact complaint? What is your complaint? She said, like most complaints we receive in case of female, she said, I'm dripping urine. Whenever I cough, whenever I brought, I bear down or I squat, I feel like something is dripping from my private part. That is the much complaint we receive from female. So in this case, the first thing that will come to your mind is hypotonic pelvic floor dysfunction because there is weakness. There is weakness somewhere that is leading to this problem. Or she said, no, I'm having difficulty in having sexual intercourse with my partner. If you ask her what is the difficulty, she said there is more pain. That complaint of pain, that is more pain, that is due to muscle spasm. That is, there is the pelvic floor muscles are hypertonic. You start gearing toward hypertonic pelvic floor dysfunction. And in case of male, the usual complaint is after the urine leakage in many adults, the elderly, their main complaint is also urine leakage. That is due to hypertonic. That is the weakness. And in male that are of age, their main complaint is I cannot sustain a good erection. So from there you can start. There is laxity somewhere, or the pelvic floor muscles, especially the ischiocabinosus and the bulbocavernosus, are not functioning well to sustain this erection. Then you move to asking the marital status. You ask the marital, is she married? Is she okay with the relationship? In case the complaint is from the sexual activity. This will also, the marital status as well as the marital relationship with the partner will guide you in designing your treatment. Then you ask her regarding her obstetric history. You ask her how many deliveries she did, because the more delivery we have, the more laxity of the pelvic floor muscles, as well as the more laxity of the abdominal muscles. Because the more we become pregnant, the more the abdominal muscles become lax. And when the abdominal muscles are lax, there is more weakness down to the pelvic floor muscle, because it's just like lower cross syndrome. Lower cross syndrome in this case. If the pelvic floor muscles, if the abdominal muscles are lax, definitely the gluteal muscle will also become lax. So if the gluteal muscles are lax, the abdominal muscles are lax, it will definitely compress down to the pelvic floor muscle, making it weaker and weaker with time, and the prolapse and incontinence will begin. Then you ask her regarding the genitourinary history. Is there any history of leakage? Is she having any urge of urine? Is she having painful urination? All these questions, you allow her to narrate her story, and you give her some cues like this. How about your urine? Do you urinate frequently? No, I have dripping of urine. Yes, so I don't have dripping of urine. I only have pains while passing the urine. You ask her regarding her medical history. Like I said before, in some patients like some with respiratory problem, because it's like the pelvic floor muscle, the abdominal muscle, the back muscle, and the diaphragmatic muscle, they work in harmony. Any dysfunction of one group of muscle will lead to dysfunction in the other group of muscles. So in this case, you ask her regarding her medical history, if she is having any respiratory distress, if she is having any back pain, if she has a protruded abdomen, maybe due to some bloatness, maybe she's having bloatness, it will all lead to pelvic floor dysfunction. Also ask about surgical history, like those that have any back surgery, any abdominal surgery, they can all link to pelvic floor dysfunction. You ask her about her lifestyle history including her diet, what she's taking, everything regarding her history, you ask her. A good history taking will narrow you toward what is expected in your examination. If you think this person is having hypertonic pelvic floor dysfunction, you start narrowing yourself toward the hypertonic side. And if it is hypertonic, you start narrowing time toward hypertonic. And if it's mixed, there is mixed complaint, she's having pain and she's having dripping, that is mixed problem. So you have to access very well for you to come out with the exact diagnosis. Then the pelvic floor assessment. At the beginning, you have to assess the patient generally. What I mean generally, from head to toe. You have to assess the posture. You ask her to stand and assess her posture. Is there any lordosis, exaggerated lordosis at the back? Is the shoulder retracted, or is it a normal position? Is the head in forward position, or is it in normal position? The neck also, because if the shoulder is retracted, it will add pressure to the chest, and the pressure will go down to the abdomen and down to the pelvic floor muscles. If there is exaggerated lordosis, then also all scoliosis, they can also link down to the pelvic floor problem. You assess the posture. Can she stand straight? You can ask the patient to stand by the wall and see if her hip can touch the wall. If her hip cannot touch the wall, it's tilted anteriorly. That is, she has tilted pelvis, anterior tilting. That is, there is a problem with relaxing her pelvic floor. So she cannot relax herself. She has anterior tilting of the pelvis. Then you can also palpate for tenderness and swelling in the body. Any place you can ask her, you can palpate and see. And then you examine her vital signs. You check the body mass index. If she is obese, you can know where to ask the patient to change in her lifestyle. Remember to document all what you have assessed, all what you have checked. Remember to document and check whether these are in line, are normal, or they are not normal. And the pelvic floor assessment, the external assessment. After the history taking, then you ask the patient that you want to assess her. Just the way I explained before, she need to undress, then she go to the couch, she need to expose her private area. You need to see and check what is wrong with her. So depending on which side to check will determine the position the patient will assume. The lithotomy position is usually assumed once you want to see the vulvar area. The lithotomy position is assumed. Once you want to check the anal area, usually the lying position is assumed, or you ask the patient to be in crook line. So the examiner should wear a non-latex glove and also apply some gel for easier assessment. For females, you observe and palpate the vulvar region. Palpate the mons pubis. Palpate it. Is there pain? Is there anything? Is there some coloration? Is there some rashes out there? You palpate the labia majora side, you palpate it, you palpate the perineal area. And around the perineal area, check for any scarring, if there is scar, because that is where usually in female they have this episiotomy. You check for scarring. If is the scar of good looking, or the scar there is more adhesions there? Is there sensation around the scarring area? Because that is where usually, if episiotomy is done, it usually results to the pudendal nerve injury, and the pudendal nerve is responsible for sensory activities of the pelvic floor area, because you ask the sensation. If there is impaired sensation, you record it. If there is anything around the perineum, you ask. You go down to the anal region, you assess the anal side. Is there any redness? Is there anything? Is there any sign of infection? Whatever you see, you have to record it. And for easier assessment and easier recording, you have to be imagining an imaginary clock on the vulvar area. The clock should assume like 12 o'clock from the pubic symphysis and 6 o'clock down around the the coccyx, and by the side, the two ischial spine will be 3 and 9 o'clock. So for easier assessment, and in case if you are not the one that will see the patient again, whoever come and pick that folder will know where the location of the pain is. Like you said, there is pain around 12 o'clock. Once any other health therapist come there, she will assess that point again to see is there pain again or the pain has subsided. That is the essence of the documentation using the imaginary clock. This is like the pelvic clock. The 12 o'clock is around the pubic symphysis area, then 6 o'clock around the coccyx, after the anal, and 2 ischial spine, 3 and 9. So if you want to assess any muscles down around here, these are the superficial muscles, for example, and if you want to assess the ischial cavernosus, you start pressing from 12 o'clock down to 3 o'clock. That is where the ischial cavernous is around. That is for the external. You palpate it deep and see if there is pain. If there is pain around that place, you are suspecting the pain is from the ischial cavernosa. Then if the pain is around the cycle of the vagina and the urethra, that is around the vestibule area, you are suspecting the pain is from the bulbocavernosa muscle. However, if the pain is in the perineal region down to the side of the buttocks, that is, you should be suspecting the superficial transverse perineal, and also down to the anus. In the anus, you can also have an imaginary clock only around the anus and palpate it just and indicate according to the number of the clock. Okay. Okay. After assessing the external genitalia, then you pat the labia majora. Once you pat the labia majora, that is where the vestibule area is in female. That is the vestibule area. The vestibule area consists of the vaginal opening and the urethral opening. You check for redness. Usually, the area is red and pepperish if there is some infection. And if the area is okay, then you proceed and ask the patient to contract her pelvic floor muscle. You observe the contraction of the muscle and see the lift of these openings. If she can contract and lift, or she can only contract without lifting the orifice, then you can see the pelvic floor muscle are somehow weak, because you cannot ascertain this is the weakness, but there is lack of lifting of those orifice. Then you ask the patient to do some coughing. If you ask her to cough, then you check for urine incontinence or any protrusion. If she cough and you see some leakage of urine, that is, you should start expecting this woman has stress urinary incontinence. And if she cough and there is also some protrusion from the vaginal orifice, then you can start suspecting this woman might have might have pelvic organ prolapse. You ask the patient to contract and tighten the pelvic floor muscle and observe the contraction and document whatever you see. This is the vestibule assessment. As I said, you have to pat the labia majora. You check the inside of the labia majora, this place, and the inside, that is the vestibule area. You check for any sign of infection, redness. You check the orifice there. There is urethral opening, vaginal opening, and the glands, opening of the glands. You check it and see. And you also document whatever you see. Documentation is very vital. Then this is an example of the pelvic floor muscle assessment, just the way I explained before, for ischial cavernosa from 1 o'clock down to, like, say, 3 o'clock, and from the right side, and from the left side, from 11 o'clock, you can check this ischial cavernosa muscle. Then the bulbocavernosa immediately external to introitus, that too, just the way I said, around the opening of the urethra and the vagina. Then for the superficial transverse perineal muscle by the side, that is 9 and 3 from the right and 9 from the left o'clock. The rebator ani, these muscles cannot be assessed superficially. You have to go inside and assess around the 5 o'clock and 7 o'clock inside, not outside. Then if it is from the rectum, it's around 3 and 9 o'clock. Then the anal sphincter, you assess it, you visualize it, and palpate for any pain or any sign of anal fissure around it, and you document also. Then in case of male, you observe the general area, you observe the penis. Is there any sign of infection in the penis? Is there some rashes? Is there any sign of bruises around the penis? You assess it and check. And you also assess the scrotum. You assess the scrotum. However, the scrotum, you can feel the testicles inside, but depending on the temperature. Usually, if the body is hot, the scrotum enlarge to allow the testicles to suck down and away from the body in order to have a conducive environment. However, it is during a cold weather, the scrotum will compress itself to accommodate the testicles inside the body for more conducive temperature. You check for redness and inflammation. You ask the patient also to cough and check for dripping of urine. This usually occurs in the elderly. You ask the patient to contract and relax the pelvic floor muscle continuously and observe how the penis and the scrotum are moving in and out in order to be sure the muscles are working in good condition. Then after the external assessment, you document everything. Then you ask her, you cannot just start going in. No, you have to tell the patient. So now I finished with the external assessment. What now is I want to go inside. If it's female, I want to go inside your vagina and assess something. You ask her if she's comfortable, can I start? It will not be painful. And if there is pain, tell me you have pain. And if you are uncomfortable, tell me, I will stop it. You allow the patient to give her the chance to express her feelings, not just go in. If she said there is pain, no, behind it, I'm coming, I want to check you, no. Ask her if there is pain and you want me to stop, ask me to stop and I will stop it. Your patient priority is first, not the examination. If you want to go in, you have to use a clean finger, a clean glove again. Then you rub your hands with a gel for easier penetration. You ask the patient to be comfortable. You want to go in. You start by tapping around the vaginal orifice. You tap around the vagina to see the vaginal wink. If she can wink, it's also something good. Does she have a good vaginal wink? If there is no wink, that is, the sensation is not that good because she cannot even wink the vagina in response to touch. She cannot even wink it. So there is some kind of problem with sensation around that area. Then you slightly proceed inside. You ask her, is there pain? If she said there is pain, where do you feel the pain? I want to touch it around the place. You assume an imaginary clock just around the vaginal wall. You start from 12 o'clock. You start palpating. Do you have pain around here? Down to 1 o'clock, 2 o'clock, continue around. Do you have pain? Do you have pain? Wherever she has pain, record it. She has pain around so o'clock. And don't just remove your hand from there. Try and make it firm around the place. Maybe there is some trigger point there. By leaving your hands firm there, it will relieve that trigger point. It will relieve it. Then you move on. and see where the pain is, until if she is relaxed. If she is relaxed and you ask her, are you okay? I want to go in. If she's okay, then you proceed. If she's not okay, maybe the pain is too much, you leave the patient. No need of pausing the patient and go in until another time. If she's okay, then you proceed in. You can place, then you start with one finger. You insert the finger gradually, asking her, is there pain? Asking her, do you feel my hand? She might say, I didn't feel anything. I didn't feel anything. That is, there is no good grab of your hand. She's not even feeling your hand. There is laxity of that muscle, the rugged of the vagina. Maybe they are loose, so she's not even sensing your hand. If she's not sensing your hand, then you can withdraw and insert two fingers. You ask her, is she feeling your hands? Yes, no, yes, I'm feeling good. Then you can proceed with other assessment. No, I still cannot feel your hand. Try, contract. She still said, I'm not feeling your hand. Then you can make, no need of coming out and add another finger. No, you have to make your fingers a little bit wide. Continue opening the fingers, continue opening the fingers until she can feel your fingers. You widen the fingers inside until she can feel it. Are you feeling? Yes, now I feel it. So from there, you can document the type of finger you use, wider finger, because she cannot, wider finger. Whoever says you document wider finger for penetration, definitely there is more laxity in this pelvic floor muscle because she cannot even have a good grasp of your hand. So even her partner cannot have a good grasp of his penis. So there must be a problem with sexual activity. Once you are here, whichever the finger is good for the woman, 1, 2, or wider finger, then you can proceed. At the moment, you insert around 3 cm into the vagina, around the first or second knuckle of the vagina. That is where you can assess your superficial pelvic floor muscles. You assess the superficial pelvic muscles. You start by, just the way I explained, around 1 o'clock, 2 o'clock to 3 o'clock is the area for the ischia cavernosa. Then you assess, you touch it. Is there pain? No, there is no pain. Then you document. You keep remembering, or you can keep asking your assistant. That is the essence of the assistant. You ask the assistant, there is no pain around the ischial cavernosa, there is no pain. Or if there is pain, where do you feel the pain? You feel some hardness around that place. Maybe there is some trigger point there. Don't remove your hand, press it a little bit to relieve the trigger points. Then you move on and assess all other muscles there. Maybe inside you feel something like, maybe there is something like maybe what will I say? You feel some bumps inside. You can ask the patient, are you feeling something here? Yes, I'm feeling. And you know there must be something there. Then you document it also. You can refer her for a gynae checkup to make sure that she's not having any other problem inside her vagina. Then you go a little bit inside. That is where the sucker layer is. Then you assess for those muscles. Then you go deep inside before you reach the cervix. That is where the levator ana and the coccyx muscle are. You assess for the muscles, the levator ana, you assess it around the 5 o'clock or the 7 o'clock. You press it around that place. You check it and see if there is any tenderness, there is pain, there is anything you feel in there, then you assess it. Then you assess the integrity of the cervix. Is the cervix too up that you cannot even touch it? You document it. Maybe it's because she's around her menstrual cycle, the cervix will go off for a little bit because it descends down for the passage of the menstruation. Maybe she's around her ovulation time. The cervix is soft, just like touching your nose. You feel it like something like floppy inside, just like the tip of your nose. You feel it. You feel the cervix opening. The cervix opening is open. That is ready for releasing No, ready for taking sperm inside, and you can feel it is soft, and there is some line of more secretions inside. Then you all document whatever you see inside. Then you gradually withdraw your hands and leave. But there are some women, they have a problem not with the penetration, but inside. Once you are inside, they are not comfortable. They will keep saying there is pain, there is pain, there is pain. So this is dyspareunia, pain with penetration, that is dyspareunia. Even if they are having sex with their partner, they used to have this problem because it's not in the vaginal opening that they have pain. That is in the vaginal opening, that is vaginismus. There is lack of penetration. So the woman cannot even allow you to penetrate for you to have the internal examination because of the pain, and the vaginal orifice is so spasm, is contracted, that cannot even allow penetration. That is vaginismus. But the vaginal orifice is relaxed, and you can go in and you can, but the problem is cannot go in and check for what you can check. Then the woman start feeling pain. That is the problem of dyspareunia. Okay. Okay. Then just the way that I already explained all these things, you keep using the imaginary clock for easier location of the pelvic floor muscle. Then you palpate for any trigger point inside. You assess for muscle symmetry. That is inside, while you are inside, you check for muscle symmetry. There might be asymmetry in one side of the vagina. One side of the pelvic floor muscle might be okay, and the other side might be so tense, maybe. And it's usually, if you have pelvic tilt or lateral tilt around the place usually mimic what is outside. Hello? Sorry, are you hearing me?
Yes, we are hearing you, ma.
Okay, thank you. The place usually mimic what is inside, what is outside. Like if you have hip pain, you contract yourself to one side. Even also the pelvic floor muscle inside will follow the asymmetry of that side, so you cannot feel the texture as similar. One will be relaxed and the other will be so tense. And also you check for any sign of prolapse if you are inside. Maybe the moment you are in, you feel some protrusion. There is something you cannot go in. Something has stopped you from penetrating inside. Definitely this is prolapse. You assess which type of prolapse it is. The prolapse, maybe the prolapse is just at the introitus. You cannot even go in. You can see the prolapse. Don't push the prolapse in. Just document the prolapse is in so grade. That is around the introitus, about 3 to grade 3, because it's not completely out of the vagina. That is 4. That is grade 4. It's inside the vagina, around the introitus. You can, and you try to push, but it's hard. It cannot go in. Just document without pushing yourself in. But if you can go in, until when you are in, you feel some protrusion and you are sure it's not the cervix that you are touching, then that prolapse is the prolapse from the pelvic organ. You assess which type of prolapse is that. Is it from the anterior surface of the vagina? That is the roof of the vagina. Is the prolapse coming from there? That is, you start suspecting is the bladder, the prolapse, that is the cystosol. No, it's not from the root. It's from the down that I'm feeling the protrusion. That is, the rectum is protruding inside the vaginal wall posteriorly. That is the rectosol. Or you can say the protrusion is not around on the vaginal wall, is straight down. Something big is coming down. That is the uterine prolapse. Yes, then you can see that the protrusion is not from down, it's not from down, it's just the vaginal wall that are collapsing down. That is vaginal vault. You assess and document whatever you see. Also, while sweeping inside in the vagina, in a circular manner, Also, check for any sign of scarring, any sign of any protrusion you see. You check the texture of the cervix, just the way that I explained before. This is a good explanation, but it's not that quite visible. It's not that quite visible for the assessment. And just the way I already explained it, but for more visibility, this is the coccyx, and this is the pubic symphysis area, and this is the finger coming from the vagina. Then once you are in, you can check for the coccygeal muscle, that is the pubis, and down to the coccygeal, that is the muscle that will encircle the pubococcygeal. That is the muscle that once you are in completely, that is the muscle that encircles the viscera, that is the pubococcygeals. You assess it. You start from the vaginal orifice, that is the first thing, that is the vaginalis. Then you go down and press down, that is around the urethra, above around the urethra, that is the urethralis. Then you sweep down a little bit around the anus, that is the analis. You check the integrity of all the muscles. Then for the iliococcygeals, that is, it starts from the ilium to the coccyx. You have to make your hands down around 4 to 5 o'clock and check it, and check the iliococcygeals. Then remember, the pelvic floor muscle, it has two accessory muscles. In the anterior, we have the obturator internus, and posterior, you have the piriformis. Check for the integrity of these muscles. You can check the anterior, you can check the obturator internus by, after placing your finger inside, you ask the woman to flex her knees and her hip, and you press down her lower abdomen for you to check the obturator internus. That is the best way to check the obturator internus, because you are putting more pressure to your hip that will compress the obturator internus, so you can touch it more anteriorly. Also, the piriformis is down. Also, you can to compress down and ask the woman to a little bit elevate her buttocks up the assessment couch. That is when you can feel the piriformis muscle. It's not an easy examination, but with practice, we can become experts. This is a clock, just the way I explained it before. For the deeper one, for levator ani, around 1 to 2 knuckles depth, that is where you can assess the levator ani. Once you inside the fingers inside the vagina, then you check it around 5 o'clock down and 7 o'clock by the left, 5 o'clock by the right. Then if it's inside the rectum, through the rectum, then you can also to assess it inside the rectum. For the obturator internus, I already explained it about, you can check it. Then rectalis, bladder, and urethra also is around 1 to 2, around 12 o'clock. That is the anterior part of the pelvis, and the coccyx from the posterior part. You can check all the rectalis muscles, the analis muscles there. Then for pelvic floor assessment, remember to assess the pelvic floor muscle function. For male, it also has to do with the assessment of the strength, endurance, and also the ability to relax the pelvic floor muscles. The pelvic floor muscle, as I said, they cannot be relaxed completely, because if they are relaxed, we cannot hold food, we cannot hold urine. So they are in low tone to aid in that continence. So ability to relax, you assess the ability of your patient, both male and female, the ability to relax the pelvic floor. You can assess them using some questionnaires. You can assess them using verbal cues. Are you able to pass urine once you want to pass, or you have to to put more effort before you pass urine, or you have to put more effort before you defecate. You all ask that questions to be able to know if there is voluntary contraction, there is voluntary relaxation of these muscles. Then regarding the strength of the pelvic floor muscle, you can assess the strength of the pelvic floor muscle using different means. You can assess it locally using, once you are inside the vagina, you assess the strength, maybe using 1 finger, 2 finger, 2 wide fingers. You can assess that, can you hold my fingers? Yes, I can hold you. Okay, contract. You can assess the contract and quantify it using some means, maybe Oxford grading scale, modified Oxford, maybe though she cannot contract. She tried as much as possible, she cannot contract. That is 0. You can feel some flicker of movement inside the vagina, but some flicker somewhere, that is 1. Yes, she can a little bit contract, but she cannot lift, that is 3. Then she can contract, she can lift, but it cannot be sustained for a long time, that is 4. She can contract, she can lift and hold it for some time, so she has a good strength of her pelvic floor. Another form of assessing the strength, there are various means. You can use some devices like periometer. Periometer, it has a good reliability and validity for assessing pelvic floor strength. It has a probe where you can insert into the vagina and assess it. We will come down to it. Then regarding the endurance is not the ability to hold. She can hold, but how many seconds can she hold is the endurance. That is, she can just hold and relax. The endurance is just 1. Maybe she can hold it. You can count 1, 2, 3. She can hold for like 3 seconds, 5 seconds, maximum 10 seconds. That is good hold. You can document it. Then regarding the weakness, usually we don't assess the weakness. However, with increase in knowledge now, there are some tools that can assess weakness. We usually concern with strength, because many people, they end up suffering than having cure. Once in the internet, everywhere there are people that prescribe Kegel. Once you come up with a problem, with pelvic floor problem, the first thing they will say, go and do Kegels. You are just harming yourself. Don't just go and do Kegels. For male and female, don't go just and do Kegels. Get someone that is not knowledgeable and assess you and prescribe you the right thing. You might not need Kegels. You might not need strengthening at all in some cases. You just need to relax and learn how to relax your pelvic floor muscle, and you are good to go. So we can assess the weakness, then we assess the speed of contraction of the muscle. How fast can she contract and relax? That is the speed of contraction and the ability to relax the pelvic floor muscles. This is a modified Oxford grading scale. We can use it if there is no contraction at all, that is 0. Very weak contraction, some flicker inside, you can feel some flicker of movement, that is 1. Then we can have the contraction is weak, maybe there is knowledge, just the way I explained, is 2. Moderate contraction with some degree of lift and squeeze is 3. There is good contraction producing elevation with some resistance, then is 4. Strong contraction and strong resistance is 5. There is also perfect R method of pelvic floor muscle assessment. The P stand for power. The power, you grade the power using the modified Oxford scale or any strength scale that can grade the power. Then you assess the endurance, just the way I explained, time in which a patient can tighten and contract, the time she can hold that tightness she has, and number of pelvic floor muscle contraction patient can hold, that is the repetition. She can repeat before the muscle become fatigued. Then the number of post-pelvic floor muscle contraction patient can perform, that is, if she can perform the first contraction, continue contraction, keep counting until she cannot go. Then elevation, does the posterior vaginal wall lift during pelvic floor muscle? Is there lift? of the muscle, not just contracting, ability to contract and lift. That is a good Kegel exercise. That is good pelvic floor muscle exercise. Then not exercise really, that is the good pelvic floor strength. The strength of the pelvic is good. You can contract and you can lift. Then do the abdominal muscle contract during pelvic floor muscle contraction. That is called contraction of other muscle. Maybe she cannot just contract, so she has to recruit the abdominal muscle. She has to recruit the gluteal muscle before she can contract the pelvic floor muscles. Then you can document also the timing of involuntary contraction, of cupping, synchronous timing. You have to synchronize the timing. The moment she coughs, then there is leakage. That is stress incontinence. She coughs and there is little delay before the leakage. That is urge incontinence. Based on the cough stress test. Then ability to relax. Can she able to relax? Ask her, relax yourself. But you still feel if you touch her buttocks or his buttocks, you feel they are a little bit contracted. Ask him, relax, but they cannot relax. In this kind of people, they have problem with relaxation. So don't add pepper to their problem. Don't give them strengthening exercise. Don't give them Kegels. Just concentrate on how they can achieve relaxation of the pelvic floor muscle. Because if you ask them to relax, you can sense some kind of contraction somewhere. Maybe for female, you can see the scrotum is just lift up. It cannot come down. Maybe the penis is little bit up. It cannot collapse. There is some kind of spasm somewhere. There is kind of inability to relax, so you have to concentrate more on relaxation of the pelvic floor muscle. Don't give Kegels in this situation. Then in this perfect, sorry, that is missing in R, in this perfect, not the perfect R1, this is another one. You also grade the power according to the 5 scale. You scale you use the scale of 1:5. Maybe you said 1:5. This patient has 2. You write 2, then the endurance up to 10 seconds. How many times she can hold? You document the second, so she can finish up to her 10 seconds. That is very great. No, it's only 1-2 seconds. You write it. Then how many maximum number of contraction patient can perform with rest in between? You can have some rest in between, so she can do the repetition. She hold, then you rest for 1-2-3 seconds. She relax, contract, rest 1-2-3 seconds. She relax. You continue. How many maximum number of contraction can she perform within that resting time? Maybe 3 seconds. She contract for 3 seconds, then she rest for 3 seconds. She contract again. She will reach a time that she cannot further continue. The muscle has reached their fatigue stage. Then number of 1 second maximum contraction patient can perform in a row. Just contracting and relaxing, fast contractions. This fast contraction is very important, especially in people that have stress incontinence. You have to teach them how to contract fast, how to contract their pelvic floor muscle fast. 1 second contraction, 1 second contraction, because it's very vital. It helps in counteracting the effect of intra-abdominal pressure. Once there is increase in the abdominal pressure, you contract. It will help in treating your patient, because don't just focus on the Kegel side that hold for 7 seconds, contract and relax. No, just pay attention more to past contraction to aid in counteracting the effect of the intra-abdominal pressure. Then every contraction time, every contraction, just the way I'm saying, you have to take how many seconds you take, how many times you take. At the end, you compile everything and see whether the muscles are weak, whether the muscles are good, or they are somehow. Then there is one skill, health assessment skill. It's the one skill that we were taught in when I had some workshop with some Indian ladies. This is the assessment skill they use for contraction and relaxation. For contraction, they can grade it as 3 if there is strong upward and inward pull against resistance. What they mean by pull against resistance, they can ask the patient to flex her legs or to flex her hip. Once there is that flexion, there is increase in resistance, or with cupping, she can have that good control with the strong upward and inward pull of the pelvic floor muscle. Then it is grade 2 if the grip with complete side compression. That is when the hand is inside, there is a sequential grip of your hands with compressive circle. The grip is so tight that is grade 2. Even if there is no that upward and inward pull, that is 2. Then there is mild contraction from any side of the vaginal wall. You can feel some contraction, that is grade 1. Then it's 0 for baseline tone. That is the normal tone. No any sign of contraction. Then for relaxation, ability to penetrate, you can penetrate the vaginal orifice, that is -1. Inability to penetrate, you cannot penetrate inside, that is -1. Then you can penetrate, but there is pain, tightness, discomfort, or any other symptoms, that is -2. Asymptomatic penetration, you can penetrate, easy penetration without anything, that is -3. That is for the relaxation side. Then there is also grading according to head subscale, that is strength, endurance, repetition, fast twitch, muscle contraction. They also use the strength, they use this for the strength and relaxation, they use this scale. For the, after the grade, then you insert the number, either is +3 or is -3. Then for the endurance, it will be for 10 seconds. Can she hold for 1 second? No, it's 5 seconds. No, it's 10 seconds. Then you document. Then the number of repetitions she can perform a good repetition, up to 10 repetitions without fatigue is good. That is 10 seconds. Then fast twitch muscle movement. How fast 1 second contraction she can pass for 10 seconds. Then you also document. There are many number of scales. We can keep searching and use scales that have good reliability and validity that can be easily quantified by you. Then there are many scales, we can search it on the net and they are everywhere. Just the way I said, this is the perinometer. Perinometer is a digital device. It's good for assessing pelvic floor muscle. It gives feedback of how the pelvic floor muscle function. It assesses the strength as well as the endurance. This is the perinometer. It has this big electrode, is the vaginal electrode, and this one is the anal electrode. You can assess the anal pressure, you can assess the abdominal pressure with the perinometer. It's not easily accessible, but it's good for women's health to have it because it's easier to assess the strength and endurance of the pelvic floor muscle. It measures the pressure changes in the vagina or in the anus based on voluntary contraction of the pelvic floor muscle. You have to apply a lubricant to the electrode, whichever one you are using. Then you insert it. If you want to start using for the vagina, you insert it into the vagina by asking the patient, explain it to her, this is a device, I want to check your strength, the ability of you to contract their muscles. Just give her a good explanation for her not to appear as if you want to do something. Then you insert it gradually into the vagina. You ask the woman to maximally contract her pelvic floor muscle. Once she maximally contract, the number of contractions will appear in the monitor. Then you record it. You ask her to do it again. She did it like 3 times. Then you take the average. That is her maximal contraction. Also, the endurance will also be there in the monitor. And for the anal, also you ask either the female or the male that you want to assess the pelvic floor muscle strength from the anal side. You ask her or him, you insert it and ask him to maximally contract the anal area and you take the measurement just the way you did it for the vaginal area, and you record it and have your measurements. Then this one can also be used as a biofeedback. That is for not only for the assessment as biofeedback device for teaching pelvic floor muscle contraction. You can ask patient, okay, contract. You are seeing how is she contracting the pelvic floor muscle, contract. Just hold it in place. Don't allow it to slip down, contract. By encouraging and giving a good verbal cues to the patient, so she may be able to recruit their pelvic floor muscle and track and start to contracting them effectively. Okay. Then vaginal cones. Vaginal cones are also set of devices that are used to assess the strength of pelvic floor muscles. They are about 20 to 100 grams. The heaviest cone a female can hold without any voluntary contraction of the pelvic floor muscle is passive pelvic floor muscle strength. They are good in teaching biofeedbacks also. They also to assess the strength of the pelvic floor muscle. You insert the small one, you ask the patient to hold it. If she can hold it without sleeping out, that is, you can say she can hold it without sleeping. Then it can slip out, but not completely out, but she can hold it a little, but it slips out, or cannot hold inside the vagina. It is totally out. That is the maximum to contraction of the pelvic floor muscle. You record it, and with voluntary contraction of the muscle, if she can hold it without the voluntary contraction of the pelvic floor muscle, you record it. If she hold it with maximum contraction, then you also record it. This is a relaxation scale. It's usually performed in the condition that they have a problem with relaxing their pelvic floor muscles. Then you can use the relaxation scale and assess the level of relaxation of the pelvic floor muscle. Like -1, that is hypertensive body. She regarded it as the patient not ready for perineal assessment and finger testing. The patient cannot even lie down. She is afraid. She has pain in that place. She cannot allow anybody to go near that place. She is so tense that she cannot even allow for any perineal assessment or finger testing. Then this is -1. The patient is ready for perineal assessment and finger testing, but not able to touch and penetrate inside. The patient is relaxed. She lie down on the couch. She open her private area, so she's ready for the assessment, but you cannot penetrate the vaginal orifice due to pimple, due to pain, due to hyperactive pelvic floor muscle. The pelvic floor muscle are so tight, maybe the abductors are so contracted and will not allow any kind of penetration. That is -2. Difficulty in penetration. You can penetrate, but it's so tight and discomfort, and there is pain, painful penetration. She lifted her hip, she adducted her hip that she cannot allow for the penetration to continue. That is the -3. Then pain after penetration, you penetrate completely, you do any assessment, but after the patient then start feeling pain. The muscles are relaxed with easy penetration, but occurrence of sudden involuntary spasm of deeper layer penetration. You penetrate inside, the muscles are relaxed, but once you went inside, there is sudden involuntary spasm of the deeper levator ani muscles, and this is -4. And easy penetration, and there is complete relaxation, no pain, no discomfort, no tightness. That is -5. This is a relaxation scale. Then after the vaginal assessment, then we go to the rectal examination. Are we good to go? Hello, everyone.
Hello, ma.
Yes,
Hello,
ma.
ma.
Yes, ma. Are we good to go? Or there are some questions, some contribution, or we are good to go?
There'll be some questions, ma. I don't know, maybe after you're okay.
Hmm? So can we attend some questions, or we can finish the letter? We can have the questions.
Okay, ma. Thank you, ma, for the lecture. This one is a minor one. I can't, when you were talking about examination,
Okay.
you said we'll use wider finger. I did not get that one. And you said
Okay.
we are not hiding another finger. How are we going to make our finger to be wider?
Okay, what I'm saying, what I mean by wider finger is that once you insert the finger, one finger like this, so she's not feeling the finger, you insert two fingers, she's still not feeling, you open a little bit, that is wider finger. You open a little bit, then you to continue opening until she can feel your fingers inside, not adding another finger again, just to continue opening the finger until she can feel your fingers inside her vagina.
Okay.
Are you okay?
Thank you, ma. Yes, ma.
Thank you. So can we continue?
Then the assessment, ma. Sorry
Okay.
for
No problem.
taking us there. The assessment that you like, because the condition is common. This prolapse. So
Yes.
differentiate is anterior, is posterior. I know you were explaining, but I did not get it very well.
Okay, okay, no problem. Once you insert your finger inside and you feel some kind of protrusion, maybe the protrusion does not stop you from going in. You can go in and do your assessment. Once you are inside the vagina, you feel the protrusion is above the wall of the vagina, that is anteriorly. Then that descent is from the bladder, is called cystosis. Then then you feel the protrusion is not above, then you sweep down, you feel the protrusion is from the posterior aspect of the vaginal wall. That protrusion is from the rectum, that is the rectus. Then you didn't feel any protrusion from up, you didn't feel it from down, you feel the vaginal wall is completely coming down, that is prolapsing down, the vaginal wall, that is the vaginal vault. No, the protrusion, you feel it at the center, directly inside the vagina at the center, not from up, not from down, not from the wall, is directly from the center. That is the protrusion from the uterus, that is the uterine prolapse. Yes.
Okay.
It is okay now?
Okay, yeah, thank you, ma'am.
You're welcome, ma. Okay, can we continue?
Yes,
Hello?
ma'am. Yes, ma'am, we can continue.
Okay, thank you. Okay, then the digital rectal examination, DRE. The DRE is performed to check the anus, the rectum, and the prostate gland, and some parts of the levator and eye muscles. In this position, the first position is either the patient should be in lateral position or lean forward. What I mean by lean forward, the patient can stand in front of a couch and lean on a pillow to expose the anal area, or the patient can lie on the couch and be on lateral side with the examiner behind the patient. You observe the anal area. You, like in female, you have to pat the gluteal muscles. For you to have a good view of the anal area, you have to pat the gluteal muscles and have a good view of the anal area. Once the anal area is visible, you check for any sign of infection around there. You check for any anal fissure. You check for anal wing. You just have to touch it lightly, and if the anal wing is present, you will see the anus is contracted and relaxed, contracted and relaxed. That is the anal wing sign of the condensation around the anus. Then you palpate it, and see if there is any tenderness or there is any discomfort around the anal area. Don't just go inside, just go inside. You have to palpate and see if the patient is relaxed. Make the patient relax. Talk to her that you want to go in, you want to assess the anal area, you want to check the inside the anal, you want to inside your finger. It's not painful, but if there is pain, just tell me, I will stop it. You lubricate your finger and you gradually insert into the anus after the relaxation of the external anal sphincter. Then you assess the pubis rectalis when you are inside the anus, maybe around 1-2 knuckles inside the anus. You can check for the pubis rectalis. You assess it around the 4 o'clock, around the 7 o'clock. You assess it, and if there is any pain or trigger point there, relieve the pain there by firm pressing, by pressing firmly around the trigger point, and you continue assessing. You document whatever you see in the examination. This is exactly what I'm seeing. This is the clock. You place an imaginary clock in the anus, and your palpation and documentation will go along the clock. The position of an anal lesion is described in relation to the pace of the clock. This is like the forward leaning. This is for the side lying, and the examiner will be at the back of the patient. And this is the patient leaning forward so that the examiner will be at the back and check the rectum and inside the finger. You can also palpate the prostate inside the anus around. If you completely inside your fingers and more anteriorly you press it, you can use the other hand to press the lower abdomen of the patient for it to be more easier for penetrate for assessing the prostate. After the assessment of the external assessment, the internal assessment of the pelvic floor, remember we have some dermatomes that they need to also be assessed in, because you can be managing your patient, keep managing your patient without achieving a good result, and not knowing that the patient has some nerve damage somewhere that is leading to that condition. So you have also to check the dermatomes of the pelvic organ. Checking the dermatomes in the pelvic region in order to identify any nerve damage. Dermatomes are skin areas that connect to a specific spinal nerve. Any deficit in nerves that supply the pelvic floor can be identified on dermatomal examination. Nerve damage could lead to lack of patient progress despite good pelvic floor rehabilitation. For female, these are usually the pelvic dermatomes are the sacral and the lumbar region and the lumbar nerves. You can, as for S1, this is around the gluteal region posteriorly, then S2 around the thigh region, then S3 composed of the vulvar area, completely the vulvar area with the exception of the perineal area and, with the exception of the perineal area and the anal area. That is the S3. Then S5 is the part of the perineum to the anal opening. S2 more down the posterior aspect of the vagina to the posterior aspect of the anus. That is for the female dermatomes. Then this is for the male dermatomes also. We need all to check it and be sure there is good function of these nerves. Then There are other ways of assessing the pelvic floor muscle. There is ultrasound. There are some radiographic examinations. There is real-time ultrasound. Usually in advanced world, the physiotherapists use ultrasound themselves, not referring it to radiologists. They use ultrasound themselves to investigate the real-time activity of pelvic floor muscle. And at the same time, they use either the surface electrode or they use the transvaginal electrode to assess the pelvic floor activity. And we can ask for magnetic resonance image in a situation that need more understanding of the pelvic floor muscles. And there is electromyography. Even physiotherapists use electromyography, but here we don't use it, but I don't know if others have started using it, but here we don't use it, but with time, by God's grace, we will reach there. It is a form of biofeedback to detect pelvic floor muscle contraction and relaxation using either internal or external probes. It's used to assess how the muscle, the ability of contraction of that muscles or the ability to contract the muscles. And you can use pelvic floor questionnaires. There are a lot of pelvic floor questionnaires, but just make sure whichever questionnaire you can use, you can make sure it has a good validity and reliability for it to be good, to have a good measurement of what you want to measure. You always remember to, while assessing, sorry, I forgot this step, while assessing the pin, you can use VAS, that you can use VAS to assess the pelvic node, to assess the pin of the patient, to rate the patient, the pain the patient presented with. You can use VAS 1 to 10 and grade the patient pain. And with subsequent visit, you can see the difference from in the perception of the pain. Maybe at the beginning she was rated 9, and later after like two weeks of treatment, it's come down to like 5. It's a good progression. But still after like 2 weeks, 3 weeks of doing the treatment, and still the patient has that pain, you need to do more of assessment and find out what is causing that problem. Because after like 2 weeks of good pelvic floor rehabilitation, the patient needs to have some element of relief from her pain. These are examples of pelvic floor questionnaires that can be used to assess pain. This is causing pelvic dysfunction screening. You can assess the dysfunction of the pelvic floor using it. There are other forms of assessment. Use peer rating scale, just the way I explained. Then other assessment, then you assess the core stability. What I mean by assessing the core stability is you assess the abdominal muscles, because you cannot go with pelvic floor muscle assessment without assessing the abdominal muscle. You assess for DR because sorry, someone is talking. Okay, you assess for DR. You assess if the pelvic floor, the abdominal muscles are lax, because laxity of the abdominal muscle can lead or it contributes more to the laxity of the pelvic floor muscles. And just the way I said, there is upper cross syndrome, and in case of lower pelvic, there is lower cross syndrome. Once the abdominal muscles are lax, the gluteal muscle that in cross manner with the pelvic floor muscles, the gluteal muscle will also become lax. The erector spinae in the back will become tight, and the iliopsoas will also become tight, because the opposite will drag the opposite. This is lax, and the other side will be tensed. So at the end, all the effort will go down to the pelvic floor muscle. It will lead to pelvic floor muscle dysfunction. So that is the essence of assessing the core muscles. Then you proceed to check the pubic symphysis dysfunction. This is because a woman can present with pelvic pain, there is pain, there is pain. You couldn't ascertain while assessing the internal examination of the vagina, you assess it, but there is nothing inside the vagina. She have a good grasp of her vagina, the strength is good, and she's still complaining of pain too. So remember to check the pelvic bones. The anterior bones, that is the pubic, where they meet, that is the pubic symphysis. You check the pubic symphysis. You check any sign of dysfunction in the pubic symphysis by palpating directly on the pubic symphysis region. You palpate it. If there is pain, you document it. If there is some sign of inflammation, you document it. Or you can even ask for an X-ray to see the gap between the pubic bones, that is the pubic symphysis, to see the gap. If the gap is more than 10 millimeter, there is definitely pain, and this woman need proper rehabilitation because the gap is too much. It's up to 10 millimeter. She need proper management, maybe using some gadget to help in bringing the muscles, to help in bringing the pubic bones together, and there is some posture correction that will help her. Then you ask for the diastasis recti. You check for sacroiliac joint dysfunction. This is more common in both male and female sacroiliac joint dysfunction. Usually, the people they present with back pain not knowing is SIJ dysfunction, and this SIJ dysfunction can occur if either the pelvic floor stabilizers are weak or they are tense. If the pelvic floor stabilizers are tense, that is they bring the ischial tuberosities so, what will I say? If they are so tight, they will pull the ischial tuberosity toward the center, and by pulling them toward the center, there will be gap in the pubic symphysis. No, in the sacroiliac joint, there will be increase in mobility around that joint, and the increase in that mobility will result to pain. And also, if the muscles are lax, they cannot hold the pubic bone, that the sacroiliac joint will be so tense and it will result to pain. So it needs to check using some physical assessment. You also check for coccydynia, that is the tailbone pain. You check for any back problem. For checking the diastasis recti, this is a beautiful picture explaining how to check. You lie down on your back, knees bent and feet apart, like shoulder apart. You place 2 fingers on your belly. You can assess it yourself, or the therapist can assess it and document it. Your belly about 2 to 3 inches above the belly button, and the other hand behind the base of your head, just to give a support to your head. You then insert the finger directly. You exhale as you lift your head and shoulder off the ground, as if you are doing an abdominal crunches. You contract your abs. You contract the abs, you pull yourself up, and you gently press your 2 fingers down the linea alba. That is the connective tissue between your abdomen, between the rectus abdominis muscles. That is the linea alba. You place your finger. You can detect if the fingers are inside. They went inside, that is showing there is diastasis recti. The diastasis recti can also be above the belly button. You can bring your hands above the belly button and also check for it. It can also be down. You can also bring your hands below and check for the diastasis recti. The therapist will guide you better in how to do it, or she can do it himself, and check if there's any form of diastasis recti. It can be above the belly, it can be in the belly button, it can be below the belly button. Then there are some physical tests, like this physical test that can be performed. That can be performed to check for any the problem, like pubic symphysis problem or the SIJ problem. For example, this is the flamingo test. Flamingo test is you have to lean to the wall, or you lean to someone and you relieve your one leg off, and if it's possible, there will be pain in the pubic symphysis or in the SI joint. If pain is there in the anterior side, is detecting pubic symphysis dysfunction, or if it is there around the gluteal region, that is SIJ dysfunction. You ask the patient to do one leg stand, just the way as it is in the picture. The patient may hope or increasing stress on the pubic bone. Then this is prone knee bending test. Prone knee bending test, you ask the patient to lie prone, you place the knee until the heel of the foot touches the buttocks. It is also called Douglas test. It's positive if there is pain in front of the thigh or around the lumbar spine. It's positive. Its significance, it can also be due to sacroiliac joint dysfunction. Then this is straight leg testing, leg test. The patient lies spine and she breaks her one leg off the couch, and it's significant if the patient have pain in her back or around the sacroiliac joint. The pain is positive. And this is Gillette test. It's also used to check hypermobility in the sacroiliac joint. If there is hypermobility in the sacroiliac joint, the patient stand and he raises one leg while pulling the opposite leg toward the chest. He pulled the leg toward the chest and stand on one leg. If there is hypermobility, there is slight shift of the therapist's hand, just the way it is in the picture. Even though it's not that well clear, there is slight shift in the abdomen, in the therapist's hand, indicating hypermobility. Then there is another physical test that can be used to check for lumbar pain or SIJ pain, or even the anterior thigh paresthesia. Then it's called Yeoman test. The patient will lie prone and the therapist will lift the knee will flex the knee to 100 to 90 degrees and then extend the hip. If there is pain around the SI joint, around the lumbar region or anterior aspect of the thigh, then the pain is significant for either lumbar pathology or the femoral nerve stretch or SIG joint dysfunction. Then the thrombolimbo test is also a sign to indicate instability in the pelvic region. You ask the patient to stand on one leg, and instead of the leg that is on the ground to be tilted, the one that is above the ground will be tilted down, showing there is weakness of gluteal muscles around that place, leading to SIG dysfunction. There are many tests, and this is also another test, Patrick test. Normal test is, okay, thank you. Yes, if there is hip joint disorders or any kind of pain. The sensitivity of this test can be depicting response from sacroiliac injection and almost 100%. is patient with lie spine and the hip is flexed. One is flexed and the other one is extended. Then pressure is applied to the flexed hip. Is said to be positive if the pain is felt across the sacroiliac joint. It's a good test and it has a good sensitivity. After performing the test, there are a lot of physical tests. These are just some form of tests, and for us to know that we need to check for the SIJ, we need to check for the pubic symphysis, we need to check for the back problem, and we need to check the hips also for any abnormality. These are not the only tests that can be performed. There are a lot of tests, but for the purpose of the presentation, I have to select some ones, and we can read further on many other tests depending on what the patient presented or what you think might be good for your patient. Things to remember after the pelvic floor assessment. After you finish the assessment, you take the patient history, you do the external assessment, you do the internal assessment, you do the physical assessment. After that, you clean the patient, you ask him to sit, you thank him for his time, and you assure him that all his data will be kept confidentially. There is no need for a therapist to go and start saying, I saw a patient, so patient has so, because we need to maintain patient confidentiality. We don't have to be roaming about saying this patient has this patient has this. And many patients, they have problem. They might feel their problem will be discussed outside. You assure him that all what has been done will be kept confidential. It cannot be discussed with any other person unless the person that might help you in achieving your rehabilitation. Remember to record whatever you did. Recording is very vital. You record how many fingers you use. Maybe you use one finger, record internal assessment using one finger, internal assessment using two fingers, or internal assessment using two wide fingers. You record it because once you want to reassess the patient, you can use the baseline data and correlate and see if your patient is improving or if the condition is getting worse or there is more to be done. Patient position during the assessment also need to be stated. You set the patient in a lithotomy position, patient in a prone position, patient in so position. You have to state the position for whatever the assessment you did. Then either the assessment is transvaginally or transrectally, or you did both. You have to state it. Then the assessment guiding will guide in designing patient treatment. Whatever you get, whatever you do, you have to match together for a proper for good designing of patient treatment. Always remember to use patient outcome. What I mean by patient outcome is whatever the patient told you, you are just trying to find more things that will help you in knowing what exactly this patient that, as she said, I have pain in my vaginal area, I have pain in my anal area. Try and see what you can do for you to know what is causing that patient pain, and you need to explain to that patient. After my assessment, I found out this, and this. And based on what we have gathered, we need to design some form of management. And I want you to be part of the management because I cannot do it alone. You are the one that you have to be part of the management. I want us to do this. I want us to do this. You are to do this. I am to do this. Explain it to the patient. Make her part of the management. We cannot just say, we are going to start Kegel. Explain her this is the reason for the Kegel. No, you don't need Kegel because your muscles are so tensed. You cannot relax the muscle. You are going to have relaxation of this muscle. But some patients can even argue, but everybody is saying I have to do Kegel. I said, yes, that is the essence of everybody, but me here, I'm a therapist. I assess you, I'm sure all other patients, all other people that are saying you have to go for Kegel, they are not, they did not assess you internally, externally, and even do all these tests for you. She will agree with you, yes. After all what you have done, this is what and what and what I see as your problem. And for this problem to be cured, we need to do this, this, and this, and this. And what you can do, this is what you can do, and this is what I can do. Explain fully to the patient, and then you plan your line of management. Basics of pelvic floor rehabilitation. Thank you so much. Before we proceed, can we have some contribution, questions, and if possible, some break for prayer? Thank you.
Thank you so much, ma. Can we ask the question now, ma?
Okay, ma.
Okay. You talk about lubrication that
Yes. Yeah.
do we have a special maybe oil for lubrication or any oil that
Yes, ma. Yes, ma. Usually for vaginal for the lubrication, we usually use either the KY gel. We usually use KY gel. We use this coconut oil. We can use coconut oil. Then you can use also the olive oil. Any oil, any good oil that it's not that bad. We can use it for lubrication, but usually we use KY gel in my clinic. We use KY gel and some kind of, if woman is okay to, she can come with olive oil or coconut oil.
Okay, thank you, ma. Then you talk about the assessment of the core muscle, the abdominal muscle. The way I do my own assessment is assessing the lower abdominal muscle by maybe ask the patient to be in supine line, raising the two lower limbs in extension just off the surface, then trying to know how long can that patient hold the lower limbs.
Okay, above the ground, above the assessment table.
Yes. Then assess the upper abdominal muscle by asking the patient to do a kind of sit up. Sit up can cause pain, but just bend as if that the patient wants to look at the tummy, then see how
like
long
abdominal
the
crunch,
patient
like abdominal crunches.
Yes, ma. So, but I don't know if there is a better way of assessing the abdominal muscle that will save time instead of assessing separately like that, ma.
Yes, because mostly in these abdominal crunches, according to some literatures, it's discouraging because the more you bring the upper body off in crunches, it will add more pressure to the abdominal muscle and worsening the pelvic floor muscle. That is why we usually don't engage women for a long time with that abdominal crunches. And it's also a bad way of just the way we grow up. We have been doing abdominal crunches for belly fat, and it's instead of the fat to go, it will just keep dilating without anything good as a result of that. So it's better you check the abdominal laxity. By mere looking, you can check the laxity, you check the abdominal circumference, the girth of the abdominal. So I can't remember now the exact girth for male and female. There is exact girth that you can measure. Once the abdominal girth is above that, it's
88 for
men,
for women, then 102 for centimeter for male.
Yes, you need to check the abdominal girth, the waist to hip ratio. Also, you need to all check it and assess it. That is the better way instead of engaging in crunches always.
Okay. What of the strength?
The strength.
So to assess the strength of the abdominal muscle.
The abdominal muscle strength can be assessed using using caliper. Also the not caliper, sorry. The caliper is you can assess the abdominal fat using caliper. You can assess the abdominal fat. Then for the strength, the best way is I can't exactly see how
I think it's the dynamometer or what do we use?
Okay, dynamometer. Yes.
No.
Usually, because we don't have this gadget, that is why I always want us to go with physical things, because all the gadgets are not usually available in our places. So we usually go with what we have at hand. That is why.
Okay, thank you, ma.
Thank you, ma.
Then you talk about that, okay, Kegel cannot be used when there is a tense muscle.
Yes, ma.
You go for relaxation.
Yes.
Can you throw more light on how we can ask?
Because the Kegels is to strengthen the muscles, and the muscles are already tensed. You cannot add pepper to the muscles. You need to relax the muscles. Relaxing the muscles, some they call it reverse Kegel. Instead of you contracting, you ask the patient, release, continue releasing, feel as if you are letting things go, give her some barbecue, let the pelvic floor as if you want them to fall down, release them, continue. Or there is some modified ways. You can have a straw and a cup of water. Place a straw inside a cup of water. Keep blowing the straw, keep blowing the water, keep releasing. To blow the straw as if you want to blow your pelvic floor. By doing that, you will feel your pelvic floor muscles are letting go gradually. That is it.
Okay, thank you, ma.
And you also incorporate breathing exercise in it. You ask the patient to take a deep breath, and she keep relaxing slowly. As she's relaxing, as she is exhaling, she keep relaxing slowly until she completely exhale. Then she take another deep breath. Then she slowly release it, as well as releasing the pelvic floor muscles.
Okay.
Thank you.
Thank you, ma.
You're welcome, ma. So is there any other question, or we can go for a break for some time and come back? Oh, the organizers, I don't know. Dr. Hafiz.
Yes, ma'am. I think there are 2 questions in the chat box.
Okay, I didn't see them. Okay, let me see.
One is asking about more explanation about pelvic floor.
Sorry, I didn't see the question. Let me check. Is anyone experiencing something? I can't hear. I came through. So
The last 2.
I want to see the question. You mentioned using non-latex glove map. Why map? And having a full bladder for assessing hypertonic condition of the patient be comfortable? Yes, we said non-latex glove because according to what we have been doing and according to what I read, non-latex glove is safest for pelvic assessment. And having full bladder for assessing hypertonic condition, the patient will not be comfortable because using the full bladder, because you are suspecting the patient have problems. So you want to check the problem, because with slide cupping, if it is someone that has good bladder, even with full bladder, he cannot leak urine. But for the purpose of this assessment, that you are thinking this patient might be having hypertonic. From the history of the patient, you might be thinking he has hypertonic condition. So the patient need to have a full bladder for proper assessment, because all the condition usually is from the bladder. You want to see how the bladder is leaking, how the assessment will go. Then I think that are the only questions.
Good afternoon.
Good afternoon, ma.
Well done for an amazing presentation so far. It's
Thank you.
really, really insightful, and I appreciate that. It was just a question about the non-latex gloves. I just wanted to add some light to it, if that's okay.
Yes,
A
it's
lot
okay.
of people
Thank you.
are allergic to latex, so they usually advise non-latex. So it can be as easy as that. And then with latex gloves, residues are being left if
Thank you
you
so much.
check and all of that. Hope that
Yes.
helped. Thank you.
Yes, yes. Yes, very helpful. Thank you, ma. Okay. Any other question?
In the absence of any questions, can we have a break?
Okay, like how many minutes?
Like an hour.
Okay, we are to
We
come
by
back after an
1:30.
hour.
Yes, 1:30.
1:30. Okay, are we okay by that?
Please, Mark, why can't you continue? Yeah, I'm having lecture
Is
by
that
2.
okay?
If it is okay, we can continue. It remains just
Please, ma,
the
let's continue. Yeah, the rehabilitation.
okay. Okay, are we okay? We can continue.
I think this is the
Yes,
last.
ma'am. Let's
Like how many
continue.
minutes more? If we know
What
I'm
is
like how many minutes more?
Let's continue, ma.
okay? Because
Can
it's
we
a
do
last
it?
part.
There are 38 people on this group. It might be better to do a poll than just take maybe just one person. If you drop a quick poll or something on the group. I am conflicted. I would like to have a rest. Sometimes I review what we've just done before I move forward. But I'm happy to continue if the majority wants to. So
Yes, please, let's continue. It's remaining just this, so we can settle down and go through.
And we don't know how long we are going to, if it's going to exceed that 2 o'clock that you said, me, I believe that we should rest because they said some people want to go and pray, and I believe we should allow them.
So what is the opinion, Dr. Hafiz?
But if all of us want us to continue, no problem.
Usually we used to have a break when it hits 12:30. There's a break. After then we will start the rehabilitation. Let's have the break. Even if it's 5 minutes.
Okay, 30 minutes to 1 hour now.
No,
What hour?
30 minutes. 30 minutes, ma, please. I have lecture by 2.
Okay, ma.
yanzu ma tana
30
magana za ta fi break 30 minutes.
Let's agree
Baba?
with that. Are we okay? Dr. Hafiz.
To ba damuwa na samu 46. Za ka iya ɗauka.
Yes, Dr.
We are to
Hafiz.
resume by 1:20.
Okay.
Ina son sai a manaki.
Okay, thank you
Na
so
ki
much.
siya. Ba ni zan more ba.
Okay, thank you so much. We are going for break.
When are we coming back?
So let's come back
1:15.
by 1, please.
Okay, ma.
Stop 30 minutes.
Bashar, zoben da ka bani ya daina tabatar mu. Amma
Sissy, sorry, just go to hospital. Let us see what is wrong.
So welcome back. I think the lecture is back now. We can continue. If you are ready now, we can continue.
Yes, good afternoon all. Hello, can we Hello? Please,
So welcome back now.
thank you. Okay, can we start or we should wait for others?
We can start.
It seems the network is somehow.
The network has been bad. The guy was telling them, let's continue. They
Dr.
were
Hafiz, are
struggling
you
with the
hearing me?
network. Yes, I'm hearing you, small, ma.
I think she's having to.
Hello, I'm not hearing from here at all.
Yes, hello everyone. I'm really sorry. I have a network problem. Are you hearing me now? Hello?
Yes, ma'am.
Yes,
We are hearing you, ma.
Okay, thank you. So can we
Yes, ma'am.
continue?
Yes, ma'am.
Okay. Now we are starting with the basics of pelvic floor rehabilitation. Before we proceed to basics of pelvic floor rehabilitation, there are some 1 or 2 things that I omitted in the assessment site. There are some form of assessment that we need to give it to our patient to go home with so that later we can assess and quantify, like the urinary diary, the bladder diary. You will give it to your patient for like 3, 4, 5 days to stay with them. In the diary, they will input their frequency of urination, the nature of urination, whether it's involuntary or it's voluntary. Involuntary in the sense that maybe there is accidental leakage due to cough, sneezing, or any other activity, or voluntary, they can go to toilet and empty their bladder themselves. Then also there is stool diary for those that have fecal dysfunction, like they have the fecal incontinence or they have constipation. You can keep them stool diary and be imputing their stool frequency and the nature of the stool. That is, whether it's watery, semi-watery, is hard, they will input it there. Thank you. So now we are moving to basics of pelvic floor rehabilitation. What I mean by basic of pelvic floor rehabilitation is that we are to take it holistically. Whatever form of rehabilitation is, either you did your history taking, recorded the patient symptoms, you do your external and internal examination, you do the other physical examination, then you compile everything and come with a patient treatment plan. So the treatment plan depends on the patient and depends on the condition you diagnose. It can be hypertonic condition, it can be hypertonic condition, or it can be mixed. For example, it can be hypertonic maybe due to laxity of the abdominal muscle. Maybe the patient has urinary incontinence, she has fecal incontinence, she has pelvic floor organ dysfunction. They are all part of hypertonic, or it can be hypertonic, maybe constipation, vaginismus, or it can be mixed. The patient can have mix of the symptoms. So whatever you assess and whatever you take from the patient, you compile together. The first thing is, before going to a hypertonic, you have to keep in your mind what is the purpose of the pelvic rehabilitation. The main purpose of there are many purposes for pelvic floor rehabilitation, depending on the condition you diagnose your patient with. But however, whatever the condition is, the main thing is to improve the patient quality of life. The patient quality of life, in the sense that you have to keep in mind that you have to improve the patient quality of life, because the patient is down, like for those that have incontinence, they are fear of going outside their comfort zone, maybe like going outside their house. They cannot go outside their house. They cannot be in functions. They cannot socialize with others due to that urine leakage, like people with BVF. That's the more people I come in contact with. And for people that are hypertonic, they usually, even in their comfort zone in their houses, they have problem with their partner. There is a problem in their sexual relationship. So she cannot accommodate her husband for sexual activity due to pains and other things. So now let's proceed. If in your diagnosis, after your assessment, after your everything, you find out that the patient has hypertonic pelvic floor condition. The most common complaint in hypertonic pelvic floor condition is pain. There is pain. Then there is pelvic floor muscle tightness. That are the most common complication, pain and pelvic floor muscle tightness. The condition that it can occur due to a hypertonic pelvic floor condition, they include vulvodynia, that is the inflammation and pain in the vulvar region. Vaginismus, that is there is difficulty in penetration. You cannot even penetrate, difficulty around the vaginal orifice. You cannot even penetrate into the vagina. There is spasm, there is pain, and there is after the penetration. You can penetrate, but after penetration, maybe during sexual activities or during your vaginal assessment, you cannot continue. The patient cannot allow you. She has pain, so you have to remove your fingers or you have to continue your sexual activity. There is also anal spasm. Anal spasm is just like vaginismus. There is spasm around the anal opening. You cannot even put your hands there. The muscle will come into. Then there is constipation. That is the inability to pass through for more than 2 to 3 days. Then incomplete voiding, you will void, but you feel like there is some ruminant inside. Sudden urge to urinate, that is urgency incontinence. Pre-permis syndrome. The pre-permis syndrome being around the pre-permis. There are a lot of, there is inflammation, there is dysfunction around the pre-permis. There is coccydynia, that is pain around the tailbone. There is big spaces, this is in a pubic area. There is pain there, and in some it's so devastating and debilitating that the patient cannot even walk. So depending on what to assess, the main thing is pain. The first thing to do here is to manage Hello, please. Hello, please. Can anyone hear me?
Yes, we can hear you.
Okay, can I continue?
We're just hearing you now.
Okay. So can I continue?
Yes, you can.
Yes,
Yes.
ma.
Okay.
Okay, thank you. So sorry, my network has problem. Okay, we are talking regarding the hypertonic pelvic floor conditions. So these are some of the conditions are not only the one for hypertonic, they are just an example of hypertonic pelvic floor condition. So the kind of rehabilitation for patients that have hypertonic pelvic floor condition, patient education. You need to educate the patient. That is the essence of the overview we had for regarding the pelvic, the pelvis, the pelvic floor, and the pelvic floor muscles. You need to educate the patient regarding his or her condition and where the problem lies. You educate him for the normal and the abnormal regarding his condition. And usually start with pain management because you need to relax your patient before you progress with any other management. The first thing to do is cryotherapy or thermotherapy using any hot pack, or you can use TENS. TENS is also a good modality for pain, depending on the area to be used. Like in vaginismus, the best way is to start with cryotherapy directly on the vulvar area, or in case of vulvodynia, directly on the vulvar area, or you can use a press bottle with chilled water and be spraying around your vulvar region. It's also a good way for pain management. The TENS, there you can use the transcutaneous electrical nerve stimulator is also a good way for pain management. IFT, also interferential therapy, is good way for pain management, and it speeds healing. Like in case of women that undergo episiotomy, IFT and ultrasound are good because they will help in speeding healing and also rejuvenation. Then you can also use the infrared as a form of thermotherapy, infrared. Then you progress to some pelvic floor muscle relaxation. Pelvic floor muscle relaxation can be achieved using different means. You can ask the patient to lie down and relax, giving her good cues that will make her pelvic floor relax. You can ask her, let go of your pelvic floor. Let the pelvic floor fall down. Feel as if you are releasing something down you. Let her release. Then you can also use the method that I described earlier, using a straw and a cup of water. Let her be blowing the water, and as well as giving her the cue to release her pelvic floor. You can incorporate the breathing exercise. You can ask the patient to take a deep breath and gradually releasing the breath through her pulse lips, as well as releasing the pelvic floor muscles together, gradually. And in case of any lifestyle modification, depending on the patient condition, you can ask her for lifestyle modification. Maybe the patient is taking alcohol. You can ask her to limit alcohol taking, cessation of smoking. You can ask her also to stop any carbonated drinks because they also has some effect in the pelvic floor muscles. Then you can progress into stretching exercise. Stretching exercise in the sense that you give some stretchings to release some tension, to relax some muscles, to lengthen the muscles. You can give some stretching exercise. There are different forms of stretching, like butterfly pose. You can ask patient to assume a butterfly pose, pigeon pose, different pose that will add in stretching to stretch her body. Then we can relieve some trigger points. We can release them using vaginal dilators, using vaginal wand. Let the patient do it herself. At the beginning, usually, if the pain is so severe, let the patient start it herself because she might be afraid for you to touch her, especially in case of severe pain in vaginismus, dyspareunia, and other pain around the vulva area, it will be difficult for a woman to let you touch her at that severe pain, during that severe pain, because encourage her, give her some counseling, educate her, ask her to touch herself using a clean finger. Touch it. How do you feel? Touch. How do you feel? Where do you feel pain? You feel here, okay, touch it slightly more. Ask her to release some tension there. Let her move. If there is pain where she has the painful area, let her touch it firmly and give some release there. Then she can use something we call pelvic wand. Pelvic wand is just like something you can even improvise it, like something like a stick, but soft one, to be touching the area. Gradually, wherever she had the pain, she can firmly press it there to release the point. Then we can give some perineal massage or some stretching around the perineal area. You can give the massage around the perineum in case if there is any pain around that area, there is scar, there is adhesions due to episiotomy. You can give a massage and stretch those muscles for a better relief. Then incorporate bladder training in case of hypertonic. For people that have urge incontinence, we incorporate bladder training. There are a lot to do, but these are just some key points. Like for cryotherapy, this is the water spray that I asked. You can get a bottle and you fill it with chill water and be spraying around your vulva. You feel a relief of pain around that place, or you can directly depress it around your pubic area. Also, in case of musculoskeletal pain, like pubic symphysis pain around the pubic area, you can use it directly on the pubic region. You can place a cryotherapy around that place directly. And for the vulva area, the chill water bottle spray is more relieving. Then regarding the TENS placement, you can place the TENS around the vulva region. These are some ways of placing the TENS placement around the pubic area. This is the pubic symphysis. Then you can place 2 electrodes there, and down around the ischial tuberosities, you can place 2 electrodes there. Then also you can have 2 placement, 2 in the pubic region, suprapubically, and 2 inside around the perineal area. There are different ways depending on where the pain is and depending on the patient. So let's move to hypertonic pelvic floor muscle dysfunction. In hypertonic pelvic floor dysfunction, from the word hypertonic, there is weakness, laxity of the muscles. The most common complaint is weakness, because usually in this case, if there is weakness, in case of female, they usually present with prolapse of the pelvic organs or urinary incontinence. However, in case of male, they usually present with fecal incontinence and sexual dysfunction. This sexual dysfunction and fecal incontinence is for all, but usually male, because there is no pelvic organ prolapse in their case, and they usually present with fecal incontinence or sexual function. The presenting complaint is the sexual dysfunction. Female, usually the complaint with leakage of urine, that is especially with stress, that is stress incontinence. With a slight increase in abdominal pressure, a female will leak. So, and some female, they will also keep it a complaint regarding sexual dysfunction. I'm not feeling anything while having sexual encounter with my partner, because there is no sensation. The muscles are not functioning very well. And even the partner also, he can also complain of having inability to sustain a good erection for sexual activity. So all these are due to pelvic floor muscle weakness. So the best thing to do in this case is to strengthen the muscles. You strengthen the muscle, you increase the muscle endurance, as well as the muscle activity, the general function of the muscle. And the muscle strength can be increased using different methods. You can increase the muscle strength using the Kegel exercise. The Kegel exercise is not just Kegel, just saying contract and relax is not just Kegel. There are different ways you can structure your Kegels. You can structure the Kegels based on the presenting condition of the patient. Like if it's due to the muscle tone there, there is problem with this slow twitch fibers there. That is where the tone is. The tone of the muscle is reduced. They cannot hold the pelvic organs very well. So you need to work hard on those muscles. That is, you contract for some time. You hold the contraction for like 3, 5, 7 seconds, then you release. You hold the contraction for like some second, then you release. That is, you are training the muscle tone. But in case of the muscle, you assess the female, so she has good strength, but in case of any increase in abdominal pressure, she may leak urine. This muscle, she has a problem with the past twitch fibers. That is, you need the Kegel that she will do will be so fast, past Kegel. She need to do past twitch contraction. She contract and relax, contract and relax. That is her problem. And you incorporate it with neck maneuver. That is, once there is increase in abdominal pressure, she contract and she release. You ask the patient cough and contract, cough and contract, or sneeze and contract. That is depending on what you assess in your patient. Regarding sexual function, usually in sexual function, the superficial muscles are mostly affected. So in this case, you need to stimulate this muscle. You need to exercise and do the Kegel exercise. You need to stimulate these muscles for proper activity of the muscles. Just like in any patient condition, patient education regarding any condition, regarding her condition, regarding the treatment she will receive is very vital, because the patient will feel she is part of her management and she will give you maximum cooperation. Because this kind of patient, you need to accommodate them very well, because once they feel insecure, they will not come back again. That is the problem with patients regarding pelvic floor. If they feel insecure with you, they will not come back again. You have to make them part of the management, appraise them, make them happy, make them laugh with you, so that they will be at ease and they should be coming for each appointment you give to them. Just the way I said, the pelvic floor muscle training, the Kegel exercise, you ask the patient to do depending on which muscle fiber you want to achieve. Then the neck technique, that is, you do the Kegel with response to increase in abdominal pressure. Then there is also polar exercise. Polar exercise is a growing conservative exercise for treating incontinence. It's like training the pelvic floor muscle indirectly. What I mean indirectly, you are to train other muscles of the body, just the way some exercise, they train the transverse abdominal muscles in respect to giving more strength to pelvic floor muscle. Because if the abdominal muscle are lax, they believe if you strengthen the abdominal muscle, you strengthen the abdominal muscle using some device, using some exercises, you strengthen the abdominal muscle. Once you strengthen the abdominal muscle, the laxity of the abdominal content will not go down to the pelvic floor muscles. So in this case of polar exercise, you are to exercise any other circular muscle of the body. Any circular muscle that you find in the body, you can exercise that circular muscle, and its effect will go down to the pelvic floor muscle. And in most of the circular muscle that is used in pelvic floor muscle is usually the eye muscles as well as the mouth muscles. Then you can use vaginal cones. Use of vaginal cones are used to train the pelvic floor muscle. You can insert the cone inside the vagina. You insert the cone inside the vagina, lightweight cone at first, not with weight. You insert it, ask the patient, is she pulling the cone? If she is pulling the cone, good. Then ask her to squeeze the cone in her and don't allow it to fall. If she squeezes it and she releases it and it falls, make her understand that she needs to hold it firm in her, even if she relaxes the pelvic floor muscle, she needs to make it not slip outside her vagina. Then gradually, as the patient is becoming aware of the pelvic floor muscle, that is the biofeedback, she's becoming aware of it. We can even use mirror for her to see how she's contracting well. Even in case of male, they can use mirror to see how they can lift their penis, they can lift their scrotum in and up. Let them appreciate what they are doing. And in this case, usually have the partner around. And if there is no partner, have someone the patient is comfortable with. Or if she's okay that you and your assistant, she's okay with you, then no problem. At least it's not you and the patient alone, because there are situations where the female or the male can become aroused. And if you think they are becoming aroused, just give them some minutes, let them be for themselves. You said, okay, let me go out after some time, continue the exercise. After some time, I will come back. Give them some privacy, let them be. It's their body natural response. Let them be for some time. Then later you can come and check whether she's okay with what she's doing. Give them mirror, let them appreciate what they are doing. And gradually you increase the weight of the cone, or you increase the intensity also for the electrical stimulation. It's also used for bioped, but let them appreciate. You can use vaginal electrode, you can use rectal electrode for them to appreciate the contraction. They will squeeze along the contraction of the electrical stimulation. Let them squeeze along with the contraction of the abdominal muscle. No, along with the EMS. Let them squeeze, let them go with the tune of the contraction. Gradually, they will peel the pelvic floor muscle and they will pick up, and you start doing the Kegel even with resistance. Then bladder training, you train their bladder, like using the bladder diary. You give the patient the bladder diary. You ask her to input whenever she urinate. You also need to break the chain of urination. Maybe she used to go to toilet after 2 hours. You ask her to reduce it with 5 minutes. Don't allow it to reach out 2 hours for you to have the urge, or for you to leak before going to toilet. Let's result maybe by 10, 15 minutes, depending on what the patient can endure. You reduce it, you train the bladder based on what the patient presented. Then breathing exercise. Breathing exercise are very good. They will relax the patient. They will aid in correct breathing, because in some cases, if the patient is having some kind of tight chest pain, chest problem, instead of doing the right correct breathing, they will end up having belly breathing, that is abdominal breathing. They will just breathe through their abdomen, and with increase in breath in the abdomen, the pelvic floor muscle will become so tense and gradually weaken. So right to teaching correct breathing exercise with the chest expansion and lowering of the chest is very vital. You also do some core stability exercise. You check the exercise for the back, the abdominal muscle, everything. And you, after checking if there is any problem regarding the core muscles, you go with the core stability exercise. Then regarding lifestyle modification. In this case, if the woman is obese, she needs to reduce her weight. She reduce her weight. If she reduce her weight, not just weight reduction, not just asking the patient, you have to reduce your weight, check her BMI. Let her know the correct BMI for her weight and height. Let her know what to do. Maybe you can incorporate the exercise in the clinic or as home program, depending on you and the patient, what you agreed on. Then you also ask her to suit on some dieting. If you can prescribe some diet for her, you know what to the prescribe, you can do so. And if you don't know, you can refer to the nutritionist for better the prescription. This is some placement of electrical stimulation. These are placement of some electrical stimulation. You place the electrode in the inner thigh. You can place the electrode around the coccyx or in the pubic area, depending on where you have the pain to relieve the pain. There are other forms of rehabilitation. Apart from the TENS, we describe the TENS, there are positionings. Positioning in the sense, incidental, you need to ask the patient the proper way of positioning depending on her condition. For instance, in case of like pubic symphysis diastasis, a patient with pubic symphysis diastasis cannot cross her leg. If she crosses her leg, she is putting more pressure to the pubic symphysis, and more joint, and she cannot also bear weight in one leg than the other. She has to balance her weight for proper alignment. And also, like in case of coccydynia, the patient need not to sit down on the floor or not to sit directly on a hard surface. She need to position herself very well that she lift her buttocks, or she place her buttocks in a soft area in order to prevent pain in that area. Then there is yes, there is use of some supports or aids. Using of some supports, like in the case of the coccydynia that I explained, you can use the coccydynia pillow. There are a pillow that you can sit on. It will relieve the coccyx off the ground for better pain relief. And in case of pubic symphysis diastasis, there is some trochanteric belt where the woman can put it to align the pubic symphysis and for better pain management. And there are then there are stabilizing exercise in case if there is problem with the pelvic floor stabilizer, the ischial, the superficial and the deep transverse perineal, you do some stabilization exercises. Then some stretching exercise as well as strengthening exercise are also vital for in case of any problem that warrant these activities. Then also hydrotherapy. Hydrotherapy is very good, or to say swimming is very effective in patients that have pain around the pelvic area. It's so relaxing, and it's due to buoyancy of water. You can do some movement that you cannot do it physically, but inside water you can do the movement due to water buoyancy. Then there is some form of massage, like perineal massage. You do massage around the perineum, you do massage in every other side of the body. Maybe if you have a problem in your SIG and you need some frictional massage there, you can give the woman, you can give the man a good frictional massage there, a good soothing relief massage for pain relief. And there is kinesiotapping. Kinesiotapping is good for pain relief also and for stabilizing. You can do kinesiotapping if you are trained to do that. You can do kinesiotapping depending on the area of pain. Then there is acupuncture. Acupuncture is also good in pelvic problems, and also depending on the meridian you can use. The spleen meridian is very good for pelvic floor problem. You can use spleen meridian. This is another reading in itself, and maybe one day we can have a presentation wholly on acupuncture for pelvic floor problems. Then ultrasound therapy also is very good in the perineal area if there is pain, if there is scar, if there is something, but you cannot just play it directly on the perineum. You can use water bag as a couple medium. You can use it around the place for like 10 to 15 minutes around the perineal area, around the vulva area, depending on where you have the pain and you want to relieve it and where you want to rejuvenate the muscle for better healing. These are not all, but these are the main things that I write. There are many things that it can be done. So this isn't, however, if there is any question that I can chip in or there is contribution from anyone, please, let's continue. Thank you so much.
Thank you
Hello.
so much, ma'am.
Hello, ma.
Yes, ma.
Please, you talked about stabilizing exercise. Please, can you, like describe it, how we should do it?
Okay. Like I said, stabilization exercise, there are exercises that are used to stabilize the pelvic or the, I'm sorry, they are used to stabilize the pelvic or the, yes, sorry. Yeah, there are exercises that are used to stabilize the pelvic or the pelvic floor muscles. Usually, you can use some kind of plank exercise. I don't have the pictures. I wanted to share the pictures, but I saw the slide are so much that just why I didn't share the pictures. Like you can do side planking. They are part of stretch exercise, plank exercise. You can do glute bridge, just like normal bridging. They are all stabilizing exercises. Are you okay?
Thank you, ma.
You're welcome, ma.
Okay. Thank you so much, ma, for this lecture. You talked about vaginal dilator that time.
Yes, ma.
I do not know if I'll be able to perform this. I don't know. I don't get the description.
Okay. Regarding the vaginal dilator, the
Okay,
vaginal
okay.
dilator. Okay, you want me to shed more light regarding the dilator?
Yes.
Okay, the vaginal dilator is a set of dilators starting from the small one. There are like 5 in numbers. Starting from the small one up to the large one. The small one is so small, just like our fingers. It's not that big. You start it, especially if there is problem regarding some penetration like vaginismus. You start around with the smallest one, you start around the vaginal orifice. You start by touching around the vagina gradually. And once the patient is relaxed and she's ready for the penetration, you start with that small probe. You insert it into the vagina. Is she okay with the penetration? Yes, she's okay. Then you can go in and out. You try it for like days. If she's okay with that one, then you progress to the next one, the one that is a little bit bigger. Then you can use it also gradually. The patient is dilating, no pain, then there is dilation. Then gradually, you continue with the other one. However, ask the patient, among these ones, which one do you think is the size of your partner? Don't go beyond the size of the partner, because if you go beyond the size of the partner, you are creating more problem. Yes, just ask her among these sizes, which one is the size of your partner? This one is the size of my partner. So don't go beyond that size, because if you go beyond that size, then there is another problem of gripping also. Just do it gradually according to the patient and the partner. So, thank you.
I think the dilator is to relax the muscle, man.
Yes, the dilator are used for relaxation, but they are also, yes, that is the essence of the dilator, for relaxation. But once the muscles are relaxed, the penetration is the problem. Some people, they have the problem with penetration. It's so tight. You have to be using it gradually, different size of dilators. Once the muscles is relaxed, even a small dilator can relax that muscle, can relax the muscle. Once the muscle are relaxed and
Okay, thank you, ma'am.
accommodate the penetration accommodated because it's bigger than the one she is used to. So you have to train it to relax it and let her accommodate the size that is so close to her partner's size. Are you okay? Or there is some confusion?
Yes, I'm okay, ma'am. Thank you, ma'am.
Okay, you're welcome, ma'am. This is just an highlight regarding what is expected for pelvic floor rehabilitation. So for a particular condition, the management will be structured in such a way on how the patient presented. It can be vaginismus. So you structure the patient management according to vaginismus treatment. If it is dyspareunia, you structure the patient management according to dyspareunia. These are just the highlight on general pelvic floor dysfunction, either hypo or hypo. So thank you so much.
I'm sorry for
No,
asking the dilatoma.
Yes,
I don't think I'm used to it. Do you have picture of it, or do you know how it can be gotten?
Yes, ma, I have a picture of it. Maybe if you can talk to me in WhatsApp.
Okay, I will appreciate that, ma.
Okay. Maybe talk to me in WhatsApp. I will send you the different size of dilators. I have some picture. I wanted to put the picture. It's just the timing. I'm so sorry.
How will I not get your number, ma?
Yes?
Your number, so that
Okay.
yes.
Okay, ma. If you can take it here, I can give it, no problem.
Okay, ma. Okay.
Okay, 070
070
3113
3113
6763.
6763.
Yes.
I'm very grateful, ma.
Yes, you are welcome.
And
so any
under
attribution?
Yes, ma'am. The little contribution I have is that
Okay.
under the education of the patient,
Okay, ma.
for especially for patients that have hypotonicity,
Yes.
one of the things that I ask them is they should avoid things that will increase the abdominal pressure. So, like lifting heavy objects, they should avoid it. Then they should avoid anything that will, if they have cough, they should treat it on time.
Yes.
And when they want to, if there is anything that can make the pressure to be increased, the abdominal pressure to increase, they should avoid it. Like anything like constipation. You talked about diet also.
Yes.
So that if you watch what they eat, so that they will not increase the pressure of the abdominal region.
Yes.
Thank you, ma'am.
Thank you. You're welcome, ma. Thank you for the contribution.
Hello, ma. Good afternoon, ma.
Yes, good afternoon, ma. How is work?
Yeah, fine, thank you. Please, you were saying something about Kegel exercises that we need to pattern it according to the condition. Please, could you reiterate what you said? I'm not sure I got it entirely.
Okay, what I'm saying is there are some patients that they are leaking, but the leaking is just due to increase whenever they have an increase in abdominal pressure. You will see they have good pelvic floor, strong pelvic floor, I say yes, strong pelvic floor muscle, but even with that strong pelvic floor muscle, with an increase in small abdominal pressure, they will leak. So in this case, you don't have to bother the woman in sustain the contraction. Maybe you contract for 10, 15 minutes. No, for 10 seconds, relax, contract, relax. No, you have to teach her past contraction of the pelvic floor muscle. One second contraction, contract, fast, contract, relax. And also incorporate the neck maneuver inside. Back the neck technique. Ask her to cough. As she's cough, just let her contract. Cough, contract, So that one will help her whenever she have an increase in abdominal pressure, the muscle will quickly contract and not let the urine to drip out. But
Okay, thank you, ma.
Yeah, welcome, ma. Sorry. Any other contribution?
Hello, good afternoon, ma.
Good afternoon, sir.
Yeah, please, do we have a role to play as physiotherapists in urinary retention in males?
Urinary retention. Yes, sir.
Hypertonic pelvic floor muscles.
Yes,
so do we
sir.
have a role to play in urinary retention? Yeah,
Yes,
thank
sir.
you.
Yes, sir. Yes, sir. We have a role to play in urinary retention. Usually, it occurs in male in this condition. You can use the pelvic vibrator. Yes, pelvic vibrator. You use the vibrator along the suprapubic area. You place the vibrator, you vibrate, and you incorporate breathing exercise. Ask the patient to be breathing in and out while you use that vibrator around the suprapubic area. Also, incorporate lifestyle modification. Ask the patient to refrain from taking any caffeinated drinks, and increase water intake. This will really help in making the bladder to relax and let go of the urine. However, if it persists, let the patient go and see the urogyne. Thank you. Are you okay, sir?
Yes, very okay, very okay. I'm
Thank
very
you,
okay.
sir. Thank you,
Then
sir.
this suprapubic pressure too, intermittent suprapubic pressure on the bladder. Yeah.
Okay. Thank you. Okay, any more contribution from us? I believe you all know this. We are just here to add more knowledge to ourselves. Any more contribution?
Good afternoon.
Good afternoon. Yes, good afternoon.
Please, madam, I don't know. I didn't get through this within the week, and I might have some
Sorry, what you said?
reactions too. Though I've gained from the one you have presented and from the people. I
Sorry.
said that I'm sorry I didn't get part of your number while you are calling. I will still read through what you presented within the week, and I have gained seriously from what you presented and from the reactions and the questions and your answers. But I
Thank
think
you.
I might have questions to make too, as in
Okay.
like that clarifications from you. That's why I'm asking for the number. I didn't get the last badge of the number while you are calling it.
Sorry, ma, which
Please.
number?
No, you called your number when
Okay, sorry, my number. Okay, do you want it?
yes, I didn't get the last part, please.
Okay, 070 3113 6763. Are you okay now?
Yeah.
Okay, thank you.
Yeah.
Okay, thank you.
Okay. I got 070. I didn't hear the other. I don't know whether it's network.
3113.
Okay.
Okay, 6763.
6763,
yes.
Okay.
Okay,
Thank you very
much. Yeah, welcome, ma.
I'm still interested. Some of the devices you listed while presenting the workshop, I don't know whether they're easily accessible in Nigeria here.
Like which one, ma?
Well, she talked of the dilator, and then you talked of the one that was used, that is meant to be used during the measurement of endurance, the perinometer.
Okay, the perinometer, they are not really available because they are so expensive, the perinometer, but I'm opportune to have one because I use it in my PhD thesis. I have one. I can show it to you since you have my number. Regarding the dilators, there are different type of dilators, and you can even improvise something that will be good for the patient. Because sometimes, based on the economic situation, we do some improvisation for patients. We can use some maybe, what will I say? There is one patient that I treated, but we have to use condom and fill it with some cotton for it to look like an erect penis, and we start with it gradually. Then later, before we even do much of the session, till she's relaxed and she's okay. So, but if we can get the dilators, it will be good. However, even the dilators, it's advisable for each patient to have his own, because you cannot be transferring it from one patient to another patient. That is the problem. Each patient has to have his own pack of dilators for home use and also for themselves, because you cannot use it. However, in some cases, we manage it by using condom in it. And after the usage, you remove the condom and discard it.
Hello, good afternoon. Yeah.
Yes, sir. Good afternoon.
Yeah, those equipment are not readily available in Nigeria, but I source for them from China. I can help them get them.
That's wonderful. So that's wonderful, sir. Maybe, sir, you can talk to us so that we can have access to it.
Yes, I will place my number. I think I will place my number on the chat box. So if you want to, yeah.
Okay, sir. That's very good. Thank you.
Okay, good afternoon, ma.
Good afternoon, ma.
Can we use the vaginal electrode when treating fecal incontinence? Maybe we improvise with the vaginal electrode to treat fecal incontinence.
Not really, ma, because you are not targeting the right muscles. You are not targeting the right place. You need to have the anal electrode. It will be better.
Okay, thank you, ma.
Yeah, welcome. Okay, Dr. Hafiz, any other? I think there is no any other question. Or any contribution from anyone that, apart from maybe I missed something? Hello?
Thank you very much, ma. In the absence of any other question or contribution, I'll call it a day for today.
Okay, sir. Thank you so much, sir. I really appreciate it. And I hope we will all learn from what we hear from me, even though there are just some basics that will guide us in treating our patients, whether they have hypertonic, or mixed. Thank you, everyone. And I hope we will march together in women's health. We really need more men in women's health and pelvic specialty group. We are no more women's health. We are pelvic and women's health specialty group, because it has been endorsed by the National Postgraduate Physiotherapy College. And our nomenclature now is pelvic and women's health physiotherapy. And I hope many men will join us there. Thank you so much.
Thank you. Thank you.
Yeah, really welcome. Thank you.
Ma, can we get the slides?
Yes,
Ma, can we get the slides?
Okay, no
Okay,
problem.
thank
I will
you.
share it. I will share it. No problem.
All right. Thank you. Thank you. You are so
You're
much
all
grateful.
welcome. Thank you.
Thank you.
You're welcome. Okay, bye-bye.
Thank you, everyone. Goodbye.
Okay, thank you so much, ma. We really enjoyed the lecture. God bless you, ma.
Thank you. Thank you. Ajasa, you really did a job well done.